Great. Great. Well, good afternoon, everyone, and good morning for those joining on earlier time zones. We are delighted to welcome you today to this first ever symposium. We will have two panels in which each panelist will speak for 7 to 10 minutes and time for Q&A. Please put your questions in the Q&A box and our moderators will present them to the panelists. And I now have the honor to turn it over to Ambassador Dr. John Nkengasong, who is both the U.S. Global AIDS Coordinator and the Senior Bureau Official in the State Department's Bureau of Global Health Security and Diplomacy. Over to you, Ambassador.
Thank you, Alexander, and welcome to esteemed colleagues. We are truly delighted to see so many of you joining this symposium today. This symposium, the first ever between the Bureau of Global Health Security and Diplomacy and dozens of universities of public health, is intended to foster further collaboration and partnerships between the U.S. academic institutions and the Department of State, in particular the Bureau of Global Health Security and Diplomacy, which was launched last year, exactly 1 year ago, by Secretary Blinken. We believe it is critical to effectively partner and collaborate with academia, philanthropy, civil society, and the private sector to catalyze innovation and integrate new approaches and expertise into our policies. Academics have served with distinction as Embassy Science Envoys, AAAS Fellows, and Jefferson Science Fellows, providing critical expertise in strengthening the State Department's engagement on global health security issues. In terms of capacity building for the State Department's diplomatic personnel and workforce, we recently launched the COCA Fellowship at Georgetown University to provide a very strong department approach such that employees can actually have a year of study in global health, as well as new opportunities for department employees to strengthen their understanding of global health security through Georgetown University's summer course. So this is really new, fresh, and extremely valuable to all of us, and we hope you'll find it useful. Over the past 20 years, PEPFAR has been deeply committed to fostering academic partnerships that have been instrumental in advancing its vision to combat HIV/AIDS globally. Our U.S. universities have played a critical role in the implementation of this life-saving program, including many. I don't want to name them, but let me just cite a few here: University of Washington in Seattle, Columbia University, University of Maryland, the Harvard University, the Institute of Human Biology, really just to name a few, Johns Hopkins, and members of the Scientific Advisory Board of PEPFAR are drawn from many academic institutions, and they contribute to their cutting-edge research, innovative solutions, and capacity-building expertise to strengthening our program. Meanwhile, universities in Africa have been empowered through initiatives like the Nursing Education Partnership Initiative, commonly called NEPI, and the Medical Education Partnership, also known as MEPI at that time, which have really helped strengthen local workforce capacity and supported sustainable, high-quality healthcare education. As PEPFAR moves forward with a renewed focus on transformative partnerships, academic institutions remain key allies in this mission, as outlined in our 5-year strategic plan, which was launched 2 years ago by Secretary Blinken. These collaborations are integral to scaling impactful interventions, driving scientific discovery, and ensuring that PEPFAR's efforts are rooted in evidence-based, contextual, relevant strategies that can adapt to evolving changes in the global fight against HIV/AIDS. Public health representatives from several universities, including Brown University, University of Chicago, Johns Hopkins University, were able to join a September 16 White House convening on Mpox to discuss the escalating Clade 1 Mpox outbreak in the Democratic Republic of Congo and several countries in Africa, and exploring opportunities to coordinate and collaborate going forward. It is really an honor to have universities, which I believe, and all of us should, that is the foundation of good public health practice and good global health practice, and subsequently good global health security practice. I now turn the mic over to Honorable Dr. Keith Martin, the Executive Director of the Consortium of Universities for Global Health, to continue with this program. Keith, over to you.
Thank you very much, Ambassador Nkengasong. We are absolutely delighted on behalf of CUGH to be participating and co-hosting this symposium with the State Department and with the Bureau of Global Health, Security and Diplomacy. And so a big welcome to all of you online. I see hundreds are joining us from across the United States and around the world, and we couldn't be delighted. As Dr. Nkengasong poignantly outlined, that there are great opportunities in the space of global health diplomacy to connect academia with the State Department and others. And the purpose of this event today, the symposium that you're all participating in, is how do we do that? How do we connect the power in academia and with other partners? And how can we connect that with the very real needs of countries around the world? And having the State Department on this as a first effort to actually drive this in the symposium with CUGH is really important, because marrying those two assets together, what the State Department can do across US government agencies and with academia in the US and around the world, is an incredibly powerful partnership to address old and new challenges, some of which were running away from us, as time, as we know, is not our friend. So just the run of show today is that we're going to have two panels. I'll be moderating the first one, and then our good friend, Ambassador Jimmy Coker, will moderate the second one. You will see from the panelists that we have an array of skills that are here, different disciplines. And those disciplines we know are critically important if we're going to address this challenge. At the end of the day, you're going to receive actually a small commentary, a little opportunity for you to provide us with feedback and input from all of you. It's going to come from my office and Sarah McGee, who's worked hard with the great team at the State Department, Teresa Sam, and others to put on today. We need you to fill that out, because that information is going to be very important at where we go from here. So if I could, I'm just going to put forth a few slides, if I may, and I'll just want to outline a little bit about the challenge that we have before us and some of the opportunities that exist. So if you'll permit me, the consortium, our consortium is based in Washington, but we have over 41,000 global health practitioners around the world, over 200 institutions, and some of you who are on this call today, this webinar, are part of that. So our essential challenge is we know that we're creating an incredible volume of knowledge, practical knowledge, important knowledge, knowledge that needs to be implemented. So today we want to take a look at how do we bridge that gap between knowledge produced, policy, and implementation to improve global health security. This is a massive challenge, and it's not being addressed as well as we know. And I think for all of us on this call, in our gut, we know it's very frustrating. But we also know that there are solutions to this and ways we can do this better. You'll see from this call today that we don't not only have those of us who are in the biomedical field, the usual culprits engaged in global health, but importantly, we have other skills. We have a leading veterinarian. We have a leading lawyer, both of who work in the space. We have ambassadors with incredible diplomatic experience. And the reason why we brought this together is, as you can see, and you know, that if we're going to bridge the gap between knowledge produced, its implementation, we need other skills. It's just not all of us in the biomedical field can do this alone. We need other skills to do that. But a pressing gap in the space in bridging the knowledge needs policy gap is that we tend to focus on ministries of health. But in point of fact, as many of our colleagues around the world have told us repeatedly, we know that it's not just health that goes into addressing improving health outcomes. It's not just health. We've got to strengthen public works, education, the environment, finance, and justice departments, because policies produced are not effective unless governments have the capability to be able to operationalize them, if they have the people, the resources, the tools, the policies, and the enforcement mechanisms so that those policies and regulations can be implemented for the public good. As many of our colleagues around the world, particularly many of my colleagues who were serving in parliaments around the world, said to us, Keith, in our ministries, we have significant gaps. So a challenge for us today is, how can we bridge those gaps? A major asset for the State Department, for all of us who are not part of the State Department, is that you have intelligence and relationships on the ground that our academic institutions don't have. Can we bridge those gaps? Are there ways to build relationships and an online mechanism so that the knowledge about who to contact, what the needs are, where those needs are, defined by the governments in those countries, are actually known and connected to their own academic institutions in their own countries, and of course to those in the United States? So what can we do? Targeting ministerial public institutional stewardship and governance, strengthening that is key to bridging the implementation policy, the knowledge policy implementation gap. Improving inter-US government agency collaboration is an issue that can be addressed at some time in the future. But facilitating these collaborations between academic institutions in the US, regional bodies like CDC Africa, State Department, the embassies that the US has, governments in those countries, is going to be important. So what's one ask? One thing that we can consider is creating an online resource center where governments in countries can post their needs, can post the exact people that one needs to talk to, so that we have the right people in the right place, and we're connecting knowledge and capability with the needs of those who are interested in addressing them. Finally, at CUGH, I'll just share with you a few things that you're all invited to join in. With the National Institutes for Health, we actually created a capacity building platform. I put the link up there because it's an open access platform anybody can use. Second, we're having a virtual Global Health Week that you're all invited to attend. It's all free, and we created it as a way to be able to have an extension of events like this, so no matter where you are, you can engage in sessions that are important to you. And say Ambassador Coker and Ambassador Nordstrom and others will be on one of the sessions, as well as sort of colleagues of Dr. Kruder from UC Davis on One Health. They'll be having a session on that. So please consider joining those sessions. Register on our website. They're all free to join. And the last 2 points, come to our annual conference if you can. It's in Atlanta, Georgia next February. We'd love to see you there. And finally, if you can join our growing network of members around the world, become part of our 41,000 person network and 200 institutions, please do so at our website, cugh.org. And so now it's my great pleasure to hand over to our good friend, Ambassador Jimmy Coker, who's going to, we're going to run our first panel, and I'm going to be doing that. So I'm going to turn this off, stop sharing my screen, and then I'm going to turn it over to our first panel. So it's my great privilege to introduce you and to the great 3 panelists that we have today. Our this panel session is going to be on how can public health practitioners influence global health policy. And so we have 3 wonderful experts in the space. First is Dr. Victor Zhao. Many of you know Dr. Zhao. He is the president of the National Academy of Medicine here in the United States. If I went through the larger bios of the 3 people I'm going to introduce, we would be here all day, so I'm not. The second is Dr. Alexandra Phelan. Dr. Phelan is a global health lawyer of great renown. She's an associate professor at the Johns Hopkins Bloomberg School of Public Health and a senior scholar at the Johns Hopkins Center for Global Health Security. And then finally, Dr. Kathleen Musil is the director of the Fogarty Center at the National Institutes for Health. So what we're going to do is each of our panelists is going to have 7 to 10 minutes. Then we'll go into a discussion for about 15 minutes. Then we're going to turn it over to you, our attendees. So please put your questions in the Q&A, and and we'll get to as many of them as we can. And that this session will end at 2:30 Eastern Time. So it's my great pleasure to turn it over to Dr. Victor Zhao. Victor, please, the floor is yours. Thank you. Oh, I think you're muted, Victor. If you
Right.
can unmute.
Okay, I got it. Thank you, Keith, and thank you, Ambassador Ngango-san, for organizing this really important meeting. You heard from the ambassador and Keith how academia is actively working on issues of global health and how, in fact, academic universities are advising on PEPFAR and global health security. I do think that connecting academia, public health, global health security community is key. And of course, you heard some of the comments they made from a global health perspective, linking organizations, public health practitioners, countries, and understanding international needs is important. So we're going to talk about creating mechanism to facilitate such interaction. So I'm going to take my assignment first as first speaker to speak to many people in universities, and particularly researchers and practitioners about how to influence policy. My assignment is to say, how can public health researchers or practitioners influence policy? I'm going to be fairly practical in this case, but I would like to be sure that we mention the future possibilities, either in the Q&A period, or maybe I can mention some things that we can do through fellowships and opportunities to work together, particularly with the new bureau. So let me start. As public health research practitioners, our mission is to protect and improve public health, the health of the public. And how we do that? We implement evidence-based practice, we advise public health strategies, we conduct research, we engage in shaping public health policy. And so why policy is so important? Because if you think about lots of what we do, it's really affected by public policy. Take COVID-19 as an example. The federal and state policy had great impact on our work. Social distancing, mask requirements, I think they're all important strategies to mitigate the spread of COVID-19. But as you all know, in our country, the implementation varies tremendously, affected by different state policies. But we also know that there are great success in public policy, such as restrict smoking areas, requiring seatbelt, and implementing mandatory childhood vaccination. And if you look at global health levels, there are really highly successful international policy and implementation, such as polio eradication, HIV control, and others. So when you take a step back and say, with all the great intentions and directions that we're going in global health, let's take the UN's SDG, for example, success of this really is contingent on commitment, policy, and implementation. That's why it's so important that we, as public health workers, find a way to influence policy. Now, to do that, I think, first of all, it's important to have evidence-informed policy that can be implemented effectively by policies that are community and culturally sensitive and trustworthy. Well, you know that these days, there's so much distrust of public health, especially from certain segments of society, anti-vaxxers and those who spread mis or disinformation, that we really have to be understanding how we're going to start, shall we say, communicating and influencing policy. So my feeling is, if we're going to do what we do well, I would say first, conduct good science. Second, communicate the findings effectively to the public and to influence decision makers. So this means that I think you who are trying to understand this issue have to understand not only communication, but navigating the policy realm, the space in which, as you heard, who do you connect with and how do you understand the needs? So for today's talk, I'd like to take two important points: communication and navigating the policy realm. Let's talk about the communication, public and politicians. You know, I'm a scientist, and most scientists and public health leaders think if we have good data and we show them the data, we should just convince them to do the right thing. Well, you know that's not quite the case. It's quite clear that when you present data and graphs, you can't frequently, you bore the non-scientists, you go over their heads, and they may even have negative effects. So I think to be compelling for us to influence policy, we have to have a way to combine data with storytelling and narratives. Storytelling helps us make complex data more accessible, more engaging, and of course, enabling a broad understanding of public health challenges. It's a powerful tool to build public support for action. Now, the second point is, if you want to really work in the policy space, you need to navigate the policy realm. And this knowledge will come from engaging in the spaces where policy is made. You already heard John Gangasar and Keith Martin talk about this. So there are a number of ways to engage. You can, for those who are actually in the academia side, trying to involve with this, I would say you can engage with professional societies. You can acquire skills through courses, fellowship, or you can work in the State Department or local departments to become more politically active. So let me say a few words about those things. So with fellowships, at National Academies, for example, we offer a whole variety of fellowship that gives scientists and health workers experience in Washington. Our Robert Wood Johnson Foundation Fellowship for now 50 years placed mid-career fellows in Congress or federal government offices where they develop legislative, regulatory proposal, and serve as subject matter expertise. For global health, certainly we talked a little bit earlier about the fact that universities are putting now forward courses like Rebecca Katz is doing. You'll hear more about this in global health security and diplomacy in Georgetown. You also have the NIH Fogarty Center that you can get involved with. But to me, if you really want to get deep experience, there are fellowships that focus on global health security and diplomacy. The American Association of Advancement in Science, AAAS, and the Jefferson Fellowship that we facilitate at the National Academies are two such examples. AAAS Fellowship assigns early to mid-career scientists to year-long positions with the government, including State Department, and the Jefferson Science Fellowship really designed to engage more senior faculty with U.S. foreign policy and international development process at the USAID and State Department. In fact, I met with some of the fellows more recently. They've done a lot of interesting stuff. But I think that the discussion going forward would be how to open these up to even early career and the mid-career. So I want to really talk to John Gangasar about the idea of expanding Jefferson Fellowship to a lot of other people who are early stage to learn about these things. Besides fellowship, of course, you can also engage with professional societies. Just heard about CUGH, or like we have American Public Health Association that have committees that draft statements to inform positions on policy, and also have government affairs and mobilized networks. So when you work with these societies, you can begin to understand how policies are being made, how do you actually prioritize your issues, and how do you work through, in fact, going forward. So this is the two areas I want to emphasize. And of course, importantly is establish credibility through your hard work, your active participation networks, and to get involved. Because you have a chance, once you have credibility, to choose what you want to work on, and people will start engaging you to work on those. Now, I think it's really important to understand, of course, how policies are being made at the state, federal, Congress, or U.S. administration. In this case, multilateral bodies, WHO, and others. And I think depending on the objective, certainly these areas would be areas for involvement. Finally, as we're going to talk more about global health security, because I talk more broadly about public health, I think the intersection of policy and academia is important. And this is an area that, as you see, that CUGH and now the new bureau is very actively wanting more people to engage. Really important. Because global health diplomacy is really important if you look at what's needed. Ambassador Gang-Sen said about the MPOX meeting, I was at that yesterday. And of course, there's lots of other discussion on pandemics and you name it. I think it's essential to know who you work with, who are the organization, government, non-government entities to address, and to acquire knowledge of how to work with these organizations. But I think the new Bureau of Global Health, Security, and Diplomacy has a great opportunity, as Dr. Ang-San is doing, in coordinating the US international response, understanding many factors, including geopolitical ones. And that's why diplomacy is so important. So I want to say, maybe later on, we'll talk about the idea that creating more opportunities for interaction, particularly through the new bureau, creating more opportunities, such as my organization, ready to work with John. Tomorrow, we're going to have a major meeting on HIV and AIDS, but going forward with new fellowships and others, and enabling CUGH to work and university work along with the State Department to create more opportunities for interaction, etc. Let me end by just giving a personal journey very quickly, how I got involved, and that gives you an idea of how networking is so important. In 2016, when I came to Washington as the new president of then the IOM, Jim Kim, my good friend, my protege from the World Bank, asked me, we need to do a report on independent evaluation of the response to Ebola. So I organized such a study. And of course, many of the recommendations were really important. So from that report, the WHO World Bank decided to establish the Global Preparedness Monitoring Board, GPMB. And I was invited to join it. GPMB, as a group of experts, thought about, one of our early reports says, we should worry about pandemic from respiratory pathogen. That was 2019. And guess what? In 2020, we had COVID-19. From then, suddenly people say, how do you respond to this in a coordinated response in medical countermeasures? I was invited to be a principal of the X Accelerator. We also talk about financing. And then the G20 high-level panel, I became an advisor to it. And then, of course, we talk about how do you do manufacturing and how do you create the 100-day mission, both initiatives that I'm now co-chairing. These are examples of networks, active participation, and contribution. So at the end of the day, my final recommendation is that it's really important to understand the issues, to be engaged, to reach out to different networks. And when you're balanced, thoughtful, and clear in your objectives, people will turn to you to be more involved. So I encourage all of you to get involved with your field. And to John, we're ready to work with you to expand your vision of letting global health diplomacy and the State Department to be a lot more open, transparent, and engaging. I'm there to work with you. Thank you.
Thank you very much, Victor, for that very powerful commentary on the opportunities that exist in global health diplomacy and how they will engage with the U.S. Bureau for Global Health Security and Diplomacy. I look forward to the discussion and boring more deeply into the points that you made. So it's a great privilege for me to introduce you to a good friend and an outstanding global health lawyer, Dr. Alexandra Phelan. Alex, the floor is yours.
Thank you so much, Keith, and thank you to the Department of State and CUGH for inviting me to speak with you today. I wanted to use this time to share with you some strategic approaches for public health to influence policy. And while these strategies may be directed at public health academia and practice, I hope they also highlight for those working in government the potential interfaces in which they can engage bidirectionally with public health practitioners. For me, these strategies are really driven by my belief that practice and service are core ethical obligations for those of us who have been in the privileged position to conduct research and be perceived as experts on certain issues. So through my work as a global public health and human rights lawyer and as a professor, I've identified 7 strategies that I think leverage public health expertise, the broader community, and the empirical work that we do. The first and foremost is advocacy and lobbying. That includes direct advocacy. So public health professionals can engage with policymakers by presenting evidence-based arguments for policies that promote health and prevent disease. That may include things like writing letters, meeting with legislators, or even providing testimony at public hearings. But advocacy and lobbying can also include engaging with broader groups. So public health practitioners can work in the process of lobbying for change with civil society organisations and advocacy groups by helping form coalitions to amplify the voices of those in advocacy groups, to push for legislative change, and importantly, to fund public health programs. The second strategy I want to identify is the one that probably sits most familiarly for those that work in public health research, is the development of research and evidence base for policy. The first is data and research. So public health practitioners can influence policy by conducting and then disseminating their research that highlight the certain impacts of health policies, identify gaps in existing systems, or the underlying scientific basis that can inform policy. That sort of data can then help justify regulations or even reform existing laws and regulations that exist. And this isn't just for scientific or social science empirical research. This can also include things like providing legal interpretations, normative arguments, and case studies from various different multidisciplinary areas of expertise. And research and evidence-based policy development doesn't just have to be through traditional pathways. It can include things like policy briefs and the development of white papers that can synthesize research that exists and make actionable recommendations for policymakers. The third strategy I want to highlight is building relationships with policymakers. So that includes actually engaging with government officials to establish ongoing relationships with local, state, national, and international policymakers that then allows you as public health practitioners to become those trusted advisors. This is one way of ensuring that health considerations are factored into broader policy decisions, including those that go beyond traditional health portfolios. Engagement with and building these relationships can also include inviting policymakers to public health events and convening. So engaging policymakers through forums, through panels to share their expertise, and also increase their understanding and buy-in in the public health research process. The fourth strategy is participating in policymaking processes themselves. Professor Zhao and his work is one example of the sorts of advisory committees that public health professionals can participate in. That includes government advisory bodies, committees, task forces that are within the government system to shape public health policy. It can also include things like public comment on policies. And this requires a large amount of proactivity and can be a heavy lift, but it can be sometimes one of the most influential ways to participate in the policymaking process. So this includes things like providing comments during the public review period on proposed regulations or policies to ensure that those health impacts are considered. Fifth, education and capacity building. So public health practitioners can actually engage and educate the public and policymakers on the health impacts of certain behaviours, environmental conditions, or social determinants, and build grassroots support within the broader public community to help create that demand for change. And also by engaging with media, writing opinion pieces, participating in interviews or podcasts, or producing public health campaigns in the media directly can help raise awareness on important issues and then drive that public support for change. The penultimate strategy, my sixth strategy, is to collaborate with non-governmental organisations. Partnering with advocacy organisations in civil society, working with NGOs that focus on specific public health, human rights, or environmental justice issues can provide additional support for influence in policy and building on their networks. NGOs and civil society often already have infrastructure for lobbying and for organising and amplifying public health messages that can really bring added benefit to that process. And finally, public health practitioners can play an important part in the monitoring and evaluation of policies. So that includes assessing a policy's impact. So looking at after policies are implemented, what are the outcomes and effectiveness of policies? And that creates a feedback loop that can help shape future policies or suggest necessary amendments to existing ones. In addition, public health practitioners can publish impact assessments. Publishing those results from policy evaluations provides that evidence that can be used to advocate for similar policies in other regions and sectors. And whilst one policy or law or regulation may only be relevant for one particular context, by building those sorts of case studies, it can help inform across many different jurisdictions and many different environments. So by embracing those 7 strategies, I think that is an initial array of ways to think about different pathways for engagement for promoting health and well-being at all levels. Thank you very much.
Wonderful. Thank you very much, Alex. That was a fantastic description and a very prescriptive one on the strategies that were very practical and deal with a number of compelling challenges that are faced in bridging the knowledge policy implementation gap. Next, it's a pleasure to turn it over to Dr. Kathy Newsel, the Director of Fogarty. Kathy, please, the floor is yours.
Thank you very much. In a minute, you can tell me if you're seeing my slides. Can everybody see the slides or somebody see the slides?
Yes, we can see it.
Okay.
Thank you, Kathy.
Okay, thank you. So thank you for inviting me here. I really appreciate being part of this panel, and I really enjoyed the comments from the other panelists. I'm going to talk a little bit about Fogarty and NIH and how we are looking at this space. I think it's important that I let you know about the Fogarty mission and recognize Rhode Island Congressman John Fogarty. Our mission is to support and advance the NIH mission through global partnerships and to address global health challenges through innovative and collaborative programs for research and training. And if you look at Congressman Fogarty, you'll see that he was a true visionary. He was ahead of his time in recognizing the importance of working together as partners in research to improve health and international relations. And, he was talking about global diplomacy back in the 1960s. So we certainly try to carry on his vision. Overall, we're looking to build sustainable global health research capacity at home and abroad. I mean, here are some numbers of scientists we have trained. Many people on this call. We have trained, we have worked with you in training others, and you'll see that partnerships and collaboration are a large part of what we do. You see some of our multidisciplinary programs there. I'll give an example of a few of these where we try to incorporate that policy component and the interactions into these programs. So we have large, actually across NIH and within Fogarty, programs on climate change and environmental health, on infectious diseases and One Health, chronic conditions, informatics, mHealth, bioethics, implementation science, brain disorders, and mental health. Now, again, many of you on this call are familiar with this program, and I hope we can get others of you familiar with this program because it's important collaboration for us with academics. And it's our launch program. And you see here the picture from our latest cohort of fellows who were here with us at NIH the first week in July. It's launching Future Leaders in Global Health Research Training Program. We work with 7 consortia, 28 US and 140 in low and middle income institutions to provide US and LMIC doctorates and US doctoral students a 1-year mentored research training in global health at established biomedical and health research institutions in LMICs. This is the third training year for this funding cycle, and our 2024 cohort consisted of 111 trainees working in 24 countries, and importantly, with 16 other NIH centers participating. So this really crosses all disciplines and a large number of institutes here at NIH. Now, here are a few Fogarty trainees and grantees that may be familiar to the CUGH, and they have become effective national and global health policy leaders. And of course, this is our goal with all of our trainees. In that launch program, we incorporate training on communication, training on the elevator pitch, training on talking to people outside of science about research projects. So we're really looking holistically at what we mean by training, and it includes career skills. And we try to bring back many of our successful former trainees and current investigators who help us along the way in these efforts. I'm just going to mention two projects that, again, look at a broader scale and look at that intersection between science and policy. One is this Data Science for Health Discovery and Innovation in Africa, or DSI Africa. And this is an initiative that has research hubs focused in Africa. It's African-led, and then many other individual research projects. But there are other components of this that I think are relevant to this group. One is the requirement for partnerships and partnerships outside of academia, and including either the Minister of Health or some other government component in this work. And the other is a track that looks at the ethical, legal, and social implications of the work. So again, trying to look at that multidisciplinary aspect that will be needed to realize health goals. I think a second good example, and you can see our steering committee here is represented by many people on this phone call, really very broad across the US government and elsewhere. And of course, we're very grateful to PEPFAR and the Office of AIDS Research here at NIH for the funding. This is the Adolescent HIV Implementation Science Alliance, or AHISA. And the goal is to leverage implementation science to enhance the effective use of evidence and help overcome implementation challenges related to prevention and treatment of HIV among adolescents in sub-Saharan Africa by catalyzing collaboration and communication among NIH-funded implementation scientists, program implementers, and policymakers. We have 80 active members, 10% are youth as of May 2024. So again, we see this as a model program for bringing together science and policy, and hope to be able to replicate this in other areas. Now, Fogarty has a deep involvement with CUGH. NIH and Fogarty had a key role in founding CUGH, and we were co-host for the first meeting at the NIH campus in September of 2009. Many of you know Peter Kilmarks, who's the deputy director here, who was a member of the research committee from 2019 to 2024, and Rachel Stirk, who was a member as of now, 2024. Peter is also chairing the CUGH International Meeting Working Group, identifying a site for the first meeting at a non-US site. And we lead or participate in a half dozen different symposia and other sessions, and certainly would be willing through this mechanism to engage on this policy topic as well as other topics. And of course, we share many leaders and board members, and just giving you one example here with Maureen Lickfeld. So In conclusion, I would say that our mission has never been more relevant. We feel that with all of the challenges in the world, that scientific training and capacity building are keys to a resilient future. And the partnership of academicians, of policymakers, of CUGH in particular, has really never been more important. And we hope to build on and strengthen these partnerships. And then finally, just to know that there are many, many ways that we try to keep you abreast of opportunities and funding opportunities in this space. And here are a few of them, but I can certainly share them with the organizers to disseminate. So with that, I will stop the share and turn it back over to the moderator. Thank you, Keith.
Thank you very much, Kathy. That was an outstanding presentation, and thank you for bringing up the deep relationships that CUGH has with many of your members of your team, including Dr. Kilmarks and others. So we're very grateful for that relationship, and of course that which we have across the NIH's 27 centers and institutes. So now we're going to go into Q&A. So I'm going to ask a couple questions just to move things along for a little bit, and then we'd like to turn it over to you. So if you have any questions and you're watching this, please submit your questions in the Q&A, and I'll do my best to get through as many of them as possible. The first question I'd like to ask is sort of sutures together some central issues that all three of you put together, and that is just what is the architecture from your perspective that could help academic institutions in the United States to be able to understand specifically what the needs are in LMICs, who to contact, that intel that we really don't have access to here, but certainly US embassies have or can get that. What's that architecture? What would it look like, and how would it function, do you think? And I'll start off, Alex, with you, then Victor, then Kathy. Alex?
I think that from my perspective, from the sort of research side of things, the core and guiding principle must always be collaboration. And if you are engaging with communities in a different place to where you live, or in different environments, including within a particular country or a state, let alone if you're dealing with internationally, I think the core component is that it's not engaging in some form of helicopter research. I think it is really, we've seen a significant amount of that sort of research engagement over an extremely long time. And I think there has been a profound shift in recent years in recognizing the ethical injustice and the extractive nature of those relationships. So I think from the practitioner side is building those collaborations between research centers, between other academics, within civil society, between civil society as well. I will leave the other speakers to speak more on the potential role of the State Department engagement. But I think what you can then do as public health practitioners is, when you are then engaged with government, particularly with, say, Department of State or international programs, being able to serve as a conduit and seeing where it's important to your role to be elevating voices on those specific issues and those specific experiences. Where you have the network advantage, being able to start to share that network advantage to address some of these historical and ongoing injustices that we see in research internationally.
Keith, you are muted.
Sorry, what's that? Sorry, thanks, Victor. So what is that, in your experience, what is that structure from your perspective that could actually better align the research that's produced with the needs in countries? Are US embassies, is there a structure and a mechanism you think that can be used to be able to provide that sort of real-time knowledge to academic institutions that they can use to engage properly and appropriately with the right people in country?
Yeah, so Keith, I quite agree with Alex. I think the issue is dialogue, transparency, and engagement. That's key. So I think when I talk to people about, for example, the issue you talked about, in particular State Department, I think most researchers and the scientists don't have much idea of what they do and how to engage. And I think the fact that John is now reaching out is really terrific, because we have to distinguish between State Department, diplomacy, and technical agencies such as CDC and others. They do similar overlapping things, but the emphasis is somewhat different. And as you said, the information about what's needed out there from a larger global health needs and diplomacy and coordination certainly rests with John's new bureau, the State Department. And my feeling, therefore, is a lot more dialogue as we're starting today. More opportunities to engage, which is what we talked about, that is creating, say, educational opportunities. For example, we heard that we're going to hear from Rebecca and others on the global health diplomacy course that can be done at university. Well, if State Department and the Bureau is able to work with a number of other universities and with you through CUGH, I think the creation of those courses are going to be terrific. I also mentioned the opportunity, for example, to create more specific training and like fellowships. I talked about Jefferson, you heard about NIH Fogarty, and of course, there's also AAAS. I feel that we need to open up to a lot more people who said, I really want to understand how it works, and engaging with those individuals in creating not only senior faculty, but mid and early career who wants to create a pathway in that regard. I think those are really good opportunities to go forward.
Thank you very much. Thank you, Victor. Kathy, from your perspective from NIH Fogarty, what do you see in your space that Fogarty is primarily the global health actor for NIH? Where do you see some of the gaps and opportunities to connect the research that's produced that NIH, the Fogarty funds, to the needs and implementation in country?
Yeah, I think it's a great question. And I should probably add that with me being new, I've been here for about 4 months. We are undergoing a strategic planning process. It's been more than a decade since we've had a new strategic plan. We think it's important to listen to our broad stakeholders, and that would include, those of you on this call, and you'll likely be hearing more about this at CUGH. But we're looking from a number of factors. I mean, I've mentioned data science. I've mentioned, climate change. It's really, again, wanting to build the scientists of the future, that we respond to these short-term challenges, MPOX and COVID, but it's really going to take medium and long-term investments to have a resilient world and a workforce that can respond to whatever the next crisis to be. So we're looking at certain geographies. Are there geographies traditionally where NIH, has not worked and we could work, that are lower resource geographies, perhaps Francophone countries in West and Central Africa, for example, where, capacity building might take a little bit more time and a little bit more effort. What are those scientific disciplines that are really needed going forward to build this resilient future? And then again, where can we have key partnerships? NIH is large, Fogarty is fairly small. And so, we want to work better together. We don't want to duplicate. We want to complement. And again, we want to make sure that, people living in LMICs have a voice here as well.
Thanks, Kathy. And I'd like to build on that. And Victor, I'd like to ask you this question. We often engage with ministries of health, but we tend to neglect other ministries that are vitally important in improving health broadly defined, particularly ministries of finance and justice. Because it's all well and good to have policies, but if you don't have the regulations and the regulations aren't enforced, then you're into the land of magical thinking in some parts. So do you have a sense of how we can do a better job and how the State Department can engage with those ministries which we don't normally engage with?
Yeah, I spend a lot of time thinking about this and working this issue. For example, Ministry of Finance will see health is a cost rather than investment, right? So a lot of discussion about the importance of health, security for health in terms of well-being, improving national security as well, and the economic impact of the cost of care and of course, cost of illness. So those arguments can go certain distance, but not sufficiently. So really what you really have to do is to expect specific areas to work on and to find common grounds. So back during the COVID pandemic, I was asked to together with Jeremy Farrar to look at ways to look at financing for global health pandemic preparedness and response. And we came up with the idea that it should be, in fact, a way to bring people together. Now, the US government, through National Security Council, that Cameron and others been talking about a pandemic fund. I think that, so what we did is we had a G20 high-level independent panel run by Tarman and Ngozi and Larry Summers, in which Jeremy and I were senior advisors to come up with a set of proposals. With the leadership of US government, and I know John Gungerson played an important role because he chairs now the pandemic fund, the G20 Indonesia presidency brought together both finance and health ministers together to work on this important issue of making sure there's fund for the future to prepare for pandemic outbreaks. So that's where we are. That's a good example. There are other areas, like many areas that require a lot more co-funding. And I think the importance, as you said, is making sure you don't only speak to yourself, but speak to the other sectors of government, making sure that you understand where their thinking is. A little bit of what I said about communication. I was describing that as an individual communication, but whatever we do, we need to understand the other partners that we need to bring together, understanding their challenges and what actually gives them the reward, and work together for solutions.
Thank you, Victor. And the point on communication, of course, as we know, is critically important. And Alex, you mentioned that in your comments. And we sometimes, communicate a lot with each other, but we tend to neglect the importance of communicating with the public. And particularly in this era of disinformation, the power and the role and responsibility of scientists to be able to share facts and evidence in this era is critically important. You've thought through this. Can you share, perhaps your thoughts of how academia and State Department and others, what academia can do better to engage with and inform the public about current contemporary issues?
Yeah, so I mean, you're absolutely right about how important this is, particularly in an era of mistrust. And we often say public health requires public trust, and that is the core. And whether we're talking about at a national or state public health level, or we're talking about perhaps the work that the Department of State is doing at the international level, it can equally be applied to the relations between states in terms of that need for trust to make advances in public health. And I think the first step for that is respect for the audience and recognizing that the public wants to be informed, that the public does want information particularly about things that might affect their health. One strategy that came up during COVID-19, particularly in the early years, was a lesson about risk communication. And I saw that sort of filter through many scientists and public health practitioners. And I think the origins might have been Tom Frieden of the CDC, but I'm not sure where it originally came from. And the idea is that, you tell people what you know, you tell people what you don't know, you tell people what you're doing to find out those answers, and then you tell people when you're going to communicate with them again, when you're going to update them. Those sorts of frameworks are really helpful for helping guide how you communicate information, and you communicate the uncertainties and the potential for our understanding of science to change. And I think preloading people with that sort of framework is really critical for when perhaps we do find out that certain interventions aren't effective or are more effective. So I think that sort of strategy, when it comes to mis and disinformation, one thing I'd point people to, if they're interested, the Center for Health Security at Johns Hopkins has produced a mis and disinformation toolkit for communicating about these issues, about, does inoculating people with potential disinformation actually make an impact in preventing their belief when they're exposed to it, say, in the media? What are the sorts of strategies that do have an evidence base for communicating? So I would turn to thinking about the expertise from people who have expertise in communications for helping craft the way you shape your messages.
Thanks very much, Alex. And before we go to the questions from those who are submitting them, and thank you everybody for submitting your questions. Kathy, the last question to you. And I was listening to the former head of the National Center for the Advancement of Translational Sciences at NIH, and he stopped in the middle of his conversation, and he said something that really resonated to me in my conversations and work with my fellow parliamentarians around the world. He said, you know, half the reason why our interventions don't work is not because we lack science. It's because we ignore the social constructs that are necessary to be able to implement the social cultural environment that's necessary. It is, if we don't have that yin with that yang, then we're not going to be able to go and implement what we need. And he sort of, you can tell the frustration in his voice. Do you have a sense at Fogarty, you know, what Fogarty maybe can do with state and others, and how do we engage with other social sciences in the implementation of research? Do you have any thoughts on that?
Yeah, it's a great question, and I agree it's critically important. I think that HISA example I gave, the adolescent HIV, is one where we've tried to do that in a multidisciplinary way. You know, HIV is a good example of where there's stigma with certain groups in certain countries and certain populations. And we've even had a research effort on overcoming stigma, you know, recognizing the importance of that. I would also say it starts at the top. You know, we have a new NIH director, Monica Bertagnoli, and she has said over and over again, our job doesn't stop when we make a new discovery or when we have a new vaccine. You know, our job stops when all people are living healthy lives. And as you've just said, you can't do that without effective implementation and without involving the social behavioral aspects of health and science.
Thank you very much, Dr. Newsel. I'm going to finish with one last question before we go to you. And this is a very specific, yes, go ahead, Victor.
There's a lot of questions about fellowship. I'd like to at least explain that if I may.
Please.
Okay, so of course there spoken to fellowship, there's many others. And what we offer, one of the questions was, do I have to be a full-time person or not? So we have a range of fellowships in which there is fellowship in residence that they have full-time in Washington. But there are others. We have 8 such fellowship for different specialties that come to learn about policy, which they only spend a quarter of the time in DC, rest of the time in a home institution. And what they work on home institution should be aligned with what they're trying to learn in DC. So that, and the institution commits supporting them this time in learning these activities. There are other types of fellowship which actually also is modified to really enable people to look at how it best fit international. So we have 4 international fellows that allows them to travel to the United States, but spend the rest of the time and work on issues together. So I just want to say there's a variety of fellowship. The Jefferson one is full-time, in fact, from senior faculty in the State Department. And that, of course, is not only the health, in many other areas. And I was simply suggesting that could be modified to include the, more early career individuals. Thank you.
Thank you very much, Victor. And I want to take one license of one last question before we go to the audience, because we have a bit of time. And this is a very specific one that relates to global health security. We know that the joint external evaluations have identified very specific gaps in the global health security architecture to prevent, detect, and respond to pandemics. So I'd like to just ask each of you, and I'll go left to right with Victor, Alex, and Kathy. If you could share with us your thoughts about how very specifically we can align the power of academic institutions facilitate that within countries, and also those of us here in the United States, with governments that have said, these are our gaps in our global health security. This is what we need to do. How do we bridge that gap very specifically? Victor, start with you, then Alex and Kathy.
I want to start with trust. I think that if you look at all the issues that is being debated in the pandemic treaty and others, I think trust is going to be a critical issue. So I think spending time developing trust with each other and within organized countries is key. And without that, you can't really get anywhere. As regards to gaps, I think it really truly had to be an understanding of what the gaps are, what the resources are, and how we, as the community of researchers, can bring the expertise to enable to assess those gaps and help understand to close them. Finally, I think it's important to understand, of course, that in the world of diplomacy and policy, people are looking really more at the priorities for the nation and for the internationally. We as researchers tend to think about science is the basis for all these decisions. So we use words like evidence-based decision. This really should be evidence-informed decision. We're understanding that there are many other factors, as you imagine, that influence a decision, that close that gap has to be considered by the policymakers and the diplomacy people. Thank you.
Thank you very much. Thank you, Victor. Alex, over to you.
So, I mean, I think there are some great examples where we can turn to where academics and researchers have helped inform the development of new areas of focus in broader global health security architecture. So not necessarily the JE specifically, but for example, the legal action package for the global health security agenda, which the O'Neill Institute at Georgetown was very involved in. But I think the sort of second aspect is kind of a lesson learned from that process, and that is the importance of having country champions. I think this is a place where the Department of State can play a really key role from my perspective. And that's that so many of these efforts to either address gaps in international frameworks or international policies about global health security often require a champion behind them to finance and push things through. We saw Indonesia's experience with the global health security agenda and informing the G20 global health security response. We saw Argentina's leadership in the legal action package for the GHSA. And there are many other examples like the pandemic treaty that Dr. Zhao mentioned, where certain issues, Brazil on pathogen access and benefit sharing, have been champions of change. And so I think that could perhaps also equally apply to the broader JE process at the higher levels rather than necessarily the implementation, and the role of state in helping facilitate those sorts of champions from countries around the world.
Thank you very much, Alex. And I would point out to the audience that Dr. Phelan put in the playbook on addressing disinformation in the chat. So thanks, Alex, for doing that. Please take a look at that. Also, Dr. Andrew Dykins, who has been a leader of ours in capacity building with our vice chair, Dr. Nancy Reynolds from Hopkins, he put in our capacity building site. So you'll get the slides. I understand that my slides were not visible to you during my comments. Kathy, any comments from you with regard to bridging that gap for the addressing the gaps in the JEs?
Yeah, again, I don't think I have a lot to add. I think I've tried to give some examples along the way. I agree with many of the points, and if we did a word cloud right now, I'm jotting a few things down. Trust would be very much up there. We say progress moves at the speed of trust, and that's absolutely true. We're listening to relationships, we're listening to networks, we're hearing words like engagement. I think those things take time. I also think that when you talk about relationships, and we saw a real shift during COVID, you know, we could maintain relationships during COVID. It was very hard to build new relationships during COVID. So, you know, I'm happy because of climate change that the world is not jumping on a plane for an hour meeting. But I'm also very pleased to see us bringing groups of people together in person, because I think that is very important to this agenda.
Thank you very much, Kathy. And so now we're going to turn, we have about 15 minutes left before we go to closing comments. So we'll go to some questions and from the audience. So one question that Seema is a former policymaker, and Seema asks, what do you think about how they can, in terms of research being produced? She says that, Seema says it's very important to be able to include government representatives in the production of research. Any thoughts about how you can include representatives from relevant government ministries at the initial stages of research so that it's relevant to the country or community? Victor, I'll start with you.
Well, I think it's always really important to make sure what you're doing is useful and meeting the needs of the local, regional, or global level. So no question, I think any good research should consult to be sure. Now, researchers think about the independence of their question, which I think is fine, but those independence should be informed by what the needs are and, in fact, what the challenges are. So I think engaging very early in determining where you want to go through consultation, I think is a really good idea. I think, as I said earlier, I do think good research has to begin to think about not only the independence of research, but how it's going to be applied. Too frequently, research are being done for discovery's sake, which obviously has its own value. But frequently, as we ask these days, how does your research impact the community? How does your research address equity issues? How would it, in fact, in the biomedical research, that your discovery is going to benefit everyone? Essential questions. So I believe that any good research question should consult broadly. And I think increasingly the work that I'm doing is to start asking for impact, at least in the consideration of how the research will make a difference. So I do think that's important, include government's point of view. Now, you asked a question about local, and obviously that's important because, you know, you can really do, as I said, about federal, global research that may or may not be applicable to local areas and regions. And so it's important to understand the very many factors that influence the local issues that you need to address as you go forward with your research and then with policy. Thank you.
Thank you very much, Victor. Kathy, I'd like to ask you this question because it's been a pressing one. Our colleagues in LMICs have a real challenge in being able to get visas to be able to do clinical training in the United States. And I know some of our team at CUGH has been working hard to develop a different type of visa for doing that. Any advice that you can, you're a U.S. government employee, but any thoughts in terms of how we can do a better job of ensuring that our colleagues in LMICs have an equitable chance of acquiring the skills in the U.S. that they need to take back to their countries?
Yeah, it's a great question. And Alex said, make sure you acknowledge what you don't know. And I have to say, I'm not an expert in this area. I will say sometimes it's a matter as simple as lead time, right? That you can't invite someone to a meeting in a week and you can't hold a meeting in a week. That if you know, we have a very skilled team here who can be helpful in getting visas and writing the letters that are needed, but frequently we run out of time. So again, I can't say I'm the expert in all of these areas, but I will say that it takes a long time to get these visas and permissions, so don't wait till the last minute.
Yeah, no, thanks. It's our folks are really trying hard around the world.
Keith,
yes,
if I may,
yeah, please.
two things. One is we're about to release on October 1st our report on the U.S. Biomedical Research Enterprise. It's a study that we did with you know, all the leading scientists. And one area that's very clear is the workforce area. We certainly recognize multiple problems with workforce in the United States, and it doesn't bode well for the future. In particular, of course, international students, international researchers, where increasingly in the biomedical sphere, large number are, in fact, people like me, immigrants, foreign workers who actually learn and stayed on. So obviously, I think we need to have a major change in immigration policy. And hopefully this report, which is addressed for the new administration or the continuing administration, will take a look at those things. That's one point. Secondly, I think these days with virtual learning, one doesn't always have to depend on in-person. I mean, the office is ideal, but there are many different ways to provide learning through virtual mechanism. And I would strongly suggest that could be a really good way to enable education, particularly of international students and trainees.
Absolutely, and it speaks to though also to a challenge and an opportunity, Victor, in terms of the digital divide that is necessary to be overcome. And Alex, I wonder if you have any thoughts. You've done such great work on communication. If you have any thoughts about how LMICs can be able to have, maybe through partnership with private sector, to be able to strengthen their IT capabilities so they can access the kind of knowledge networks that that Victor mentioned.
So I think I think my insights are probably limited to perhaps some of the lessons of what not to do. I think there is increasingly greater recognition from philanthropy, from the private sector, from governments about the importance of infrastructure and digital infrastructure, and that includes investments in those technologies, whether we're talking about something from the research lab to the communications tool. The big issue that I've seen in this space is the supply or the sharing of technologies that are incredibly specific to either that government donor or to that private lab or philanthropy. And when funding is inevitably shifted or changed, you don't want research labs or public health practitioners to suddenly be left with a tool that is not interoperable with things that they may get from other sources or developed locally, and essentially just have obsolescence in the technology based on funding cycles. So I think the biggest thing to keep in mind is how can you plan for that longevity of technology. You know, we all know that the fax machine is a perpetual part of public health information sharing, but part of that reason is because of that the challenges of data interoperability. So I think that's one of the big lessons I would think put in there is yes, the latest and greatest might be particularly useful for this point in time, but how do we ensure that sustainability of infrastructure?
Thanks, Alex. There's another question from Catherine who submitted this, and Victor, I'm going to give this to you, and anybody else wants to put this in it. And it's got to do with how do global health practitioners, how do they engage with U.S. government diplomats who can train them? And maybe this is a question that that Ambassador Coker will investigate. But from your perspective, is there a way, or would it be how can U.S. government diplomats who understand the nitty-gritty of working in LMICs and the politics that they have to navigate on a daily basis at embassies, is it be desirable to have a mechanism for those embassy staff to be able to provide that kind of training, maybe online with global health practitioners, so they have a better understanding of the real politic you have to deal with on the ground?
Yeah, I think you mentioned, Keith, that you are starting an online resource area, which is really important because people need to ask these questions and have a way to get them answered. But I think that's only the beginning, because what you're implying, of course, is that a lot more opportunity to have more systematic interaction. And we've talked about this throughout this, I think, this panel, the idea that I think the opportunity of going forward with both what's being offered, such as Rebecca's doing, but bringing in fact, the diplomats and foreign embassies to engage in this discussion, And I think it goes actually bi-directionally useful because of hearing also what global health people are thinking. But in LMIC, clearly is the engagement of the right people to have this discussion. And then, of course, expanding further into the experience that one can get in working alongside with the diplomacy and in low-income countries. So I think the whole opportunity is right there. It's really an issue of, what do we want to do with it? What's our capacity of doing this? And what, in fact, is the outcome that we want to get? Suffice to say that we all believe that this is going to be a really, really important direction.
Thank you very much, Victor. Kathy, I'd like to ask this question. It came in the Q&A, and it's got to do with, do you have any thoughts at Fogarty about actually providing training for public communication? Is that something that Fogarty is looking at?
Well, I would say training for public communication is incorporated into many of our current programs. I'm assuming somebody might be talking about that as a standalone training program. And I would say, and we always say, if it's based on science, right? If we're looking at the science of communication and someone can pose a research question, reach out to us, go to our website, talk to an individual program officer, and we will see where it can fit. But in terms of communication as an integral part of professional development, that is part of our training programs. And to Victor's point, we're looking more that if one of our grantees develops an effective program, then yes, that can be shared in a wider way virtually, for example.
Keith, there's nothing more important than getting on the ground experience in communication. So there's a lot of work done, including at academies, about what's the best way of science communication. And Alex talked a little bit about that. I talked a little bit about that. But, until you really understand people, until you really understand where their sensitivity issues, their culture are, your communication is going to be talking to them, talking at them, rather than talking with them. So I think communications is a lot more than theoretical and teaching in classroom. It's really learning how to work with people, understand their sensitivities.
Yes, that's so true. And I think that back to the previous question that somebody posed about engaging with State Department officials, would be able to provide that type of real world training, as you mentioned, that's vitally necessary to have the real world skills and being able to listen first, speak later. So we're going to go into this to wrap up, but before we turn it over to our next panel led by Ambassador Jimmy Coker. And so let's ask our wonderful panelists to be able to, if they have a minute or two, to be able to make any final comments. I'll start with Dr. Newsel, then Dr. Fail, and then finally Dr. Zhao, and then I will thank everybody. Kathy, please.
Yeah, so thank you. Again, this has been terrific for me. I mentioned that we're going through a strategic planning process, so I was listening very carefully to, everything that everyone had to say. I think it's important to remember that we are a research organization, but we are the largest funder of biomedical research in the world. And in fact, all of our 27 institutes and centers provide some sort of funding on international health and to other countries. So if I can leave the audience with one message, it is that we provide many resources. We provide many training programs. I encourage you to reach out. I encourage you to go to our website. And again, from the Fogarty standpoint, it's all about partnership. So we thank CUGH for the partnership.
Thank you very much, Kathy. Your folks are well embedded, Dr. Kilmarks and others, and we're very grateful for the long-term relationships that we've had with you, and also, of course, Dr. Roger Glass, your predecessor. So thank you. Alex, please.
So I think the last thing I want to flag and underscore is it's really critical to realize when we're talking about engagement with communities, when we're talking about developing research networks, when we're talking about embassies on the ground, I think it's critical to realize that those conversations, that capacity building and those lessons that can be learned must not be seen as simply in the direction of high-income countries to low and middle-income countries, or from non-Indigenous to Indigenous populations. You know, there are important and expert research efforts, advocacy examples, you know, policy models and technologies that can be shared, you know, horizontally, or importantly also from LMICs to high-income countries, or for Indigenous populations from non-Indigenous populations. And so I think seeing whether we're talking about, you know, State Department engagement, or we're talking about public health research or practitioner engagement, that we're part of a network with that bi-directionality and not simply coming from a top-down approach or from a US-centric approach.
Thanks very much, Alex. Really important points. Victor, please.
Yeah, I said very early, as public health researcher practitioners, what do we really want to do? I think our mission is to protect, improve health of the population, and of course, in this case, global population. So we have to do it through science, but we also have to do it through communication, and we have to do it through strategy, and finally, importantly, influence policy. Because at the end of the day, you can't get your work done if the policy are not behind you. We learned that from COVID-19. So Alex talked about 7 strategies, which is just terrific. But I would say at the end, it's about engagement. It's about experience, about networking and opportunities. This is where I believe that you guys are offering is the opportunities to say how to learn about these areas. I would say, finally, policy is not simple, like if you know what the good science is, you ought to do it. It's influenced by many, many other factors. You mentioned about finance, but I would say community, cultural, economic, many other issues. So really understanding the policy side of things, the diplomacy side of things, is important for researchers. This way, the research will be more effective by understanding how to target the research to support the policy that's needed, so that there's evidence-informed policy that's going to be helpful globally and nationally.
Thank you very much, Victor. And to finally close on that, the comments that you've all made, I think to all of the attendees, what you've heard, of course, is some very poignant and very specific reflections on how we can bridge that gap. I think those of us working in academia certainly see that there's a certain culture. It's not the same culture as exists in governments. As Dr. Zhao mentioned, and as a former politician, I can tell you that you're operating under a very different environment where you have guardrails. Those guardrails are political, cultural, and economic, and the decisions that you make are not linear. Sometimes they're very difficult to understand why people do what they do at a political level. But at the end of the day, the government is the primary steward for the resources and have the primary responsibility for delivering the public programs that their citizens need. And our role, and hopefully as we move forward, working with the State Department, we look forward to bridging that gap in very practical ways so that governments can direct us, if they want, as to what they need to do and what the broader academic community can do to be able to support them in their efforts to address the current and future global health challenges that they face. And at CUGH, I would encourage you, although my slides didn't come up, you'll get them, cugh.org. Please join us if you can. Check out our virtual Global Health Week, September 30th to October 3rd. It's free. Anybody in the world can attend. We need you to attend because, as was mentioned by Victor, Alex, and Kathy, we are only as good as we are together. So we need you to come together with us at CUGH. We will provide those platforms and take a look at that capacity building site that we put up, and come to our conference in Atlanta. We would love to see you if you can. Well, you'll see many of the people here there too, and you can engage with them. Please check out the work that they are doing at the National Academy of Science, at Johns Hopkins, at Fogarty, and broadly at NIH. You'll see a host of valuable tools. Please take a look at them. Please use them. And now it is my great pleasure to be able to turn over the reins to our good friend, Ambassador Jimmy Coker. Ambassador Coker is somebody, at least speaking personally, has been a guide and a friend for myself, but also for so many others on this call. He has been one of the great public servants in the United States, serving around the world in the interests of the United States, for the United States and for the world. And it's just really an honor, and with immense gratitude, Jimmy, that you've joined us to lead this next panel. Please, it's good to see you, and the reins are yours.
Thank you very much, Keith. And I think that we have a very strong foundation to build on, because the panel was informative, engaging, very timely in talking about issues that we face, the intersection, as our panel is called, the intersection of global public health institutions, the intersection of public health and diplomacy. And we have, I think, if anything, the second half will be even more stronger than the first half of this day, because we have a wonderful panel who have a variety of experiences and perspectives that I think will keep the audience informed. It's a very long afternoon, but was pleased to see how much engagement there's been in the chat and in the Q&A, and we will try to keep your interest over that time. I'll just start by saying that I was a U.S. diplomat for 30 years, then became number 3 in the PEPFAR program at the State Department, went on to be head of AIDS at UNICEF, and came back in the Obama administration as the Assistant Secretary for Global Affairs at our Department of Health and Human Services, and then joined a lot of NGO boards and was kind of activist for a little while, and have been back since 2021, just a few hours a week as a re-employed annuitant in John and Kengasong's bureau here. He was nice enough to invite me back to the new Bureau of Global Health Security and Diplomacy, which I was part of the team that recommended that bureau to Secretary Blinken, because I've long been an advocate of a greater diplomatic role in global health, and seeing some opportunities that we were missing because the US at least didn't mobilize our diplomatic personnel and our diplomatic resources to be able to achieve public health goals. And I think that I'll just take 1 minute to say my experience. I got to be ambassador twice in Burkina Faso and then in Uganda. And I was in Uganda when the President's Emergency Plan for AIDS Relief, the PEPFAR program, started. And PEPFAR changed a lot of lives, and mine was one of them. And it was remarkable in part because whereas US had been involved in global health for many years, almost always our interventions in low and middle income countries had been as proof of concept or a pilot program or a center of excellence. And those programs were very capably done by USAID and by CDC. But PEPFAR was different. This was national scale up. We needed over 2 years to try to reach everyone in Uganda, for instance, and at the time 13 other countries who needed antiretroviral treatment and had little access to it without the program's help. And we needed to do so right away. And what I quickly realized was that the difference between national scale up and a proof of concept at one site required some skills that diplomats actually could contribute to. At first needed procurement and supply chain, but we needed to solve political problems and economic problems. We're going to be working in conflict areas. We needed to address ethical issues. We need to address sociological issues. And as many of you have pointed out in the comments and questions, these were issues that social scientists, that people outside of the traditional medical and public health professions actually could contribute some expertise on and help achieve those public health and medical goals, which were the purpose of the program. So just in that context, I recognized that the intersection of diplomacy and public health was not just an academic exercise, but was one that actually was going to be key to the success of the PEPFAR program. And as a diplomat, we need often just-in-time information. And of course, diplomats rarely read peer-reviewed journals, and how we access that information to have, as Victor Zhao said, evidence-informed policy. How do we access that evidence? Because in many of the articles which you are very good at writing and provide the data and the conclusions, the solutions to the problems that we're trying to address, many of those articles begin with assumptions. Well, none of the research was done with women of reproductive age. None of it included adolescents. Most of it was done in the United States or in a first world country. What might be the difference if we were to actually try to reach everyone who needed help in a situation like the HIV epidemic in Africa? Because diplomats need just-in-time information, and we need to weigh the risks. And if those academic articles always start out with assumptions and end with more research needs to be done, that's not a good place for a diplomat to start. We need to figure out, we don't have time to do more research. We don't have time to do 10-year longitudinal studies of whether this drug might have consequences of which we're not aware. We need to make a now or never decision. Are we going to go ahead with this program, scale it up, and is the benefit going to far outweigh the risk that we're taking? So the question of how do we interpret academic language and for those risks for a policy-making audience, and one which certainly is used to dealing with analyzing risk, but maybe not in a biomedical or academic sense, is important. And just finally, my contact with academics, and I thought Alex Phelan did a wonderful job of talking about getting to know each other and understanding each other's work. Invite policymakers to your campuses, to your events. But in finding those country champions that she mentioned, when we would have researchers come to a place like Uganda, often with HIV research, the principal investigators or the sub-investigators that they would be dealing with almost always were people already known to the embassy. These were the same people with whom we were working in US government financed programs or with previous contacts. And if they weren't, they were probably people we should know. And so it's very important for us to exchange knowledge just to find out, are these people who are champions, what are their comparative advantage? Who in country is already working on the issues that you're interested in? And how can that exchange of information or those parallel projects promote synergies in the work that both of us are doing? And so I just say that as an ambassador, the contact with academics who are working in the country where you're accredited are very valuable. We welcome that contact. We hope you would stop by the embassy. We realize that it's not always instant that you can get access. You probably have to arrange your visit in advance, but make the extra effort to do that, because the people with whom we're working and sharing the information which we both have about what's going on in that country and what challenges we face is well worth it. So with that introduction, I'm going to introduce our exceptionally distinguished panel here, starting with Anders Nordstrom. And Anders is currently an advisor at Karolinska Institute and the Stockholm School of Economics, based in Stockholm. And he's the principal senior fellow at the UN University International Institute for Global Health, which is based in Malaysia. But he's perhaps best known as the former Swedish ambassador for global health, the former head of the Swedish International Development Agency, and the acting director general for the World Health Organization in 2006-2007. Anders, it's been a pleasure getting to know you over many years, and I'd love your insights on the questions of public health institutions and diplomacy.
Thank you so very much, Jimmy and colleagues, for inviting me, and also that we have a bit of collaboration and input from the other side of the Atlantic as well, which I really appreciated listening and learning a lot in terms of what, again, is happening on the other side of the Atlantic. As Jimmy was saying, I was the Swedish ambassador for global health for 13 years. I was actually the first ambassador for global health to be based in the Ministry of Foreign Affairs when I was appointed in 2010. My background is as a medical doctor from the Karolinska Institute, and I'm going to come and talk a bit about why being a doctor is not enough if we're going to be successful for global health. I've had the privilege during the 30 years I've been working on global health to be involved in a number of political global health processes. And I learned quite a lot, both in terms of what has worked and what has not worked so well. Just a few examples. In 2002, I was the interim executive director, making the Global Fund up and running and navigating in the political landscape, and especially between the G8 and the United Nations at that time. Many lessons to learn from how that was possible, not what needed to be done, but how it was possible. As Jimmy said, I was heading WHO for a period. Again, many lessons in terms of the political processes around that. Victor was referring to the panel, the G20 panel on the pandemic. I had the privilege of leading the secretariat for the other panel that was working in parallel with President Sirleaf and former Prime Minister Helen Clark, called the Independent Panel on Pandemic Preparedness and Response, IPPR, and we came out with our report 2021. I'm just giving those examples of what happened in history, because my main message here is that learning from those examples, or when I was the head of the WHO country office in Sierra Leone during the Ebola outbreak, it's not enough knowing what to do. We need to know how to make it happen. It's not enough to have our public health experience and knowledge. Again, I'm a medical doctor, but I actually did also political science in parallel to my medical studies. And we've been speaking about the need here for science. There is also science to politics. There is political science. There is political economy. So that is my message here. I think when we engage with academic institutions across the world, make that match in between public health and political science. Some of us are doing that. I know Rebecca is going to speak about that. You are doing that very much. But there are very few, I would say, in the global health community that have that sort of political lens, and also, and I will come to that in a second, the skills for how to navigate in the political landscape. We are, unfortunately, as health professionals, a bit naive, thinking that evidence is enough. And as long as we have the evidence, things will work. That is not true. What I've been doing now during the last year is to establish a new program on politics and diplomacy for health. As Jimmy said, I'm associated with the Karolinska Institute and the Stockholm School of Economics. I'm very deliberate to have a School of Economics with political economy and public health. And we have established a program for mid-level career people that have already experienced from regional or global political processes. We have just finalized the first cohort of 28 fellows from 21 countries. We haven't taught anything. We're not teaching anything. The whole program has been based on, somebody was using the word storytelling, by talking to each other, the 28 people speaking, interacting, learning from each other, and with 20 absolutely top-notch faculty members, Jimmy being one of them. Jimmy was together that day together with the former health secretary from India. She was speaking about what she actually did. How did she manage the COVID-19 pandemic in India? All of them were speaking about not what to do, but how did they do it? The former president of AstraZeneca, who happened to be Swedish, was there and spoke about how did we handle when the AstraZeneca vaccine became quite challenged. I'm doing this program as a former ambassador with a former minister from Sweden, Gunilla Carlsson, and this interface in between then the public servant and the politics. And that is what I learned a lot during my 13 years as an ambassador. And part of that time I also worked with Gunilla. Gunilla was my minister at that time. So I think if I should give some advice to the academic institutions, that is to think around both basic training for public health officials or public health programs, but also for medical programs, of course, is to think about how you can bring a little bit more of political science and political lens into that. The same thing for research. We know a lot, of course, on the biomedical side, on the public health side, but there is not so much research done in terms of how to make it happen. Why is it happening? What are the key ingredients or the key factors that are making it happen or not happen? And there is need for funding for this. It's quite difficult to get funding for this interface in between political science and public health. What we also have done, we have now, and this has just in some way exploded, started with a lot of support from Rebecca, also a network of institutions across the world with a similar interest on politics and health and diplomacy. but very narrowly focus on that, not doing global health or health broadly, but specifically the interface in between diplomacy, politics, and health. So we have 31 institutions across the world. There are 9 institutions across the world that today are offering programs. In the US, of course, we'll hear from Rebecca, we're doing it in Sweden, Canada, the UK, but also in Pakistan, in China, in Japan. We are right now also working and learning from 4 new programs that are emerging. One is in Uganda and Rwanda, a collaboration in between 2 African universities. Again, focus on how can one equip people to navigate in the political system. They're doing that in collaboration with the African CDC. And there's an emerging program happening in Singapore and one in Australia as well. I will end just to make this a little bit more concrete, because we have been speaking about diplomacy and what skills are needed. And based on my experience and also what we have been using as the sort of framework in the program that we have been running now, are some very practical skills, and I share those with you. There are 7. The first one is to be able to understand who is actually deciding. Decision-making, formal and informal decision-making. If you believe that the board of the Global Fund is where the decisions are taken, you are wrong. Decisions are taken somewhere else before the board meeting. They're just confirmed at the board meeting. If you believe that the minister is taking the decision, you're totally wrong. You need to speak to the political advisor. So that's the first skill, to be able to understand the landscape, the powers, who's got powers, not got power, and know how to navigate in that landscape. The second skill is then, somebody was mentioning trust, and we've been speaking and working a lot around that issue, but not just saying trust, but how do you actually create your network and create that trust? What are the tricks that will enable you to have the trust of people so that you can call someone and you can get the help that you need? And there are tricks and there are experiences for how you create your networks. Third, you mentioned communication. What is critical here in diplomacy for health is also the timing. When do you say certain things? How do you say it? What language do you use? So communication is critical, of course. We try also in this to try to bring in a little bit learning from the private sector, from entrepreneurship. Because being an entrepreneur, running a company, is not that very different from being a diplomat in terms of wanting to achieve some certain things. We also bring in, which is the 5th one here, taking calculated risks. Especially people in the public sector doing health diplomacy, we are quite scared of risk. We are not expected to fail. Again, if you think about private sector pharma, they will fail constantly. They should fail. If you don't take risk, you're not going to be successful. So we try to bring in this as well in those discussions. Have we examples of where you have pushed the boundaries, taking a risk, and also you have failed? And how have you coped then to be able then to come back when you have failed? And the final one is about, of course, your passion and your ethics about what you're doing and being honest with that. And if you can combine those skills, and that is what we're trying to do with a new generation of leaders, we might have leaders that will not just lead, but also transform and change and take windows of opportunities and are prepared to move when there is something that needs to be done. Those are some reflections from my side, but I think the key message is here in between politics and health. So I think now the programs around global health, very, very important when it comes to the health aspects, but it would also be very useful to bring in more of knowledge, both in training programs for different levels of people, but also in the research to understand and to bring in a little bit more political economy and political science. Thank you.
Thanks so much, Anders. Fascinating. And I was taking notes. I'm sure many people were of your 7 key points, and we'll get back to those. The distinguished second speaker is Dr. Christine Kruder-Johnson, who's a professor of epidemiology and ecosystem health and director of the Epicenter for Disease Dynamics, the University of California at Davis. She's a former U.S. science envoy last year in 2023, and a veterinarian. So Dr. Kuda Johnson, welcome.
Thank you so much, Ambassador. And thank you also to the Department of State and CUGH for bringing us all together to get to discuss health and diplomacy, which you don't often find in a panel together. So I'm really excited. You're having me recall that I actually double majored in biology and political science in college. So I think from the get-go, I saw the value of bridging these fields. As was said, I went on to become a veterinarian and an epidemiologist. I started out studying epidemics in wildlife in particular, quickly noting how animals are such good sentinels for our changing environment. And I have been doing this ever since. As a professor of epidemiology and ecosystem health at UC Davis. I'm not only interested in looking at patterns of disease, but also in understanding the environmental drivers that underlie these patterns. I became personally, like many of my colleagues, very involved in public health as we started to increasingly recognize that emerging infectious diseases in particular predominantly came from wildlife. And as a society, we hope to be able to move from this very reactive response to outbreaks to ultimately a more proactive way of preventing outbreaks and thinking about the upstream drivers that cause outbreaks. So for my opening remarks, I just want to convey, I think, two key points that I think will in many ways emphasize and reiterate much of what has been said on the first panel and this panel already. The first is I would like to certainly emphasize the need for a One Health approach in research for global health. We know that pandemic risk and emerging infectious disease risk is increasing. We, I think, increasingly need to look at emerging infectious disease as this irreversible consequence that we are witnessing from ecosystem change. We know that the pre-emergence phase of epidemics and pandemics is still very mysterious to us, but we do know that zoonotic spillover is widespread and that this underpins a lot of the large-scale outbreaks that we have seen certainly across the last few decades. We know that it's especially wildlife species that have either lost habitat or have been exploited in one way or another across the decades, specifically through hunting and the wildlife trade, that have been sort of at the root cause for many of the zoonotic transmission events that we have observed. And so when we think about mitigation and prevention of spillover and outbreak risk, we can really only think about achieving these through upstream prevention, looking at the underlying root causes that facilitate disease transmission across these animal-human interfaces. And that has underpinned a lot of the work of myself and my colleagues here at our institution, in collaboration with many folks around the world. And as has already been said, I think this requires a reasonable evidence base. And from my perspective, we need to certainly bring in the ecosystem level processes to be able to ultimately inform prevention. And really, this is just emphasizing the case, that proof of concept for the need for One Health research to be able to frame risk and solutions in this sort of preventive perspective. And as has been said on the first panel and already again just now, these solutions must be developed and implemented at the community, the local community level specifically, as we saw again with COVID-19 response around the world, really. The most effective disease control and prevention measures can really only be successful with trust from the communities that's built from the ground up in partnership with the communities that are most effective, that are ultimately those local decision makers who need the information. And I would like to emphasize that the infectious disease and epidemics are they're not the only example of sort of these 21st century threats that we see that will benefit from the One Health approach, or the planetary health perspective, as it's often called. Harmful algal blooms, antimicrobial resistance, climate change, biodiversity loss, food insecurity going forward. all of these issues require this One Health lens and One Health research to be able to understand how the animal, human, and environmental aspects are interconnected, and often this is in very complex ways. So I would say that the One Health approach is fundamental to preventing the worst of many of the outcomes. And academic institutions around the world are increasingly at the forefront of One Health research that takes the sort of One Health perspective in both education as well as research. And you know, what does this actually look like in practice? I think fundamentally, what we're talking about is encouraging and deploying the resources needed for transdisciplinary team-based science. That's not often the way that we're taught as early career professionals to do research. You're taught to be the principal investigator and to take a leadership role in the work that you do in your lab. But really, we need to think about science that needs to happen, certainly within the One Health approach, as being a very team-based sport. This goes far beyond just bridging the medical and the veterinary sciences. We need to focus on integrating the environmental sciences and increasingly advanced technological innovations that are going to massively benefit this research space. It's very difficult to bring in the many disciplines that are needed to achieve these goals. We know that, you know, as research moves forward in time, we increasingly specialize, but we certainly need at least a cursory understanding of other disciplines so that we can effectively communicate across the disciplines. So in many ways, this requires sort of a step backwards. The One Health approach, I really believe it's nothing new in many communities, but it's certainly something that many of us in higher institutions have taken on as a response to what is increasingly specialized knowledge in most disciplines. And there are many correlates with the approaches that we need to do that are very, very core to diplomatic skills. So we need humility, we need a willingness to understand another way of thinking. We need to be open to another context for looking at a problem. And we also need retention of knowledge, especially age-old knowledge, centuries-old knowledge in some cases of how ecosystems have functioned for a long time prior to industrialization. In many ways, this is indigenous knowledge, incredibly valuable in helping us find a way forward. I think that our collective goal has to be, as has been said, to effectively inform action through community engagement and public policy, but to do this well, as has also been said, we need to make sure we integrate social science. Social scientists are the key to informing what policies will actually be effective. We have One Health solutions in mind as scientists, but these can't be effective, but we still don't even understand why people are doing the things that we do and how to change things to be able to improve society. And then the second point that I just want to emphasize before I turn this over to my colleague, Rebecca, is that international leadership and cooperation is absolutely critical. We need to bring science diplomacy into our everyday practice as educators and scientists at the university. We know that the challenges in addressing these global risks are daunting and they're shared globally. We know that it will be impossible for any one nation to tackle any of this in isolation. So international diplomacy is thus critical. And I want to echo Ambassador Coker's comments that the diplomatic corps is an incredible resource. They are one of the most multi-talented and knowledgeable experts doing the hard work of implementing the policy on these same issues all over the world. And they're essential collaborators in the work that we need to do globally. And I think science diplomacy is one of several highly effective ways to ensure that we have international collaboration and support international relationships with other countries. As a scientist, I have seen how powerful it is to network researchers across continents, share advances in new technology, and just, you know, generally share the same issues, the same challenges that we all face, all the way from the field to the lab to implementation. And I'm always amazed how internationally connected our universities are. So we have a lot of ground that we have already built. there are major efforts that are increasingly elevating a diversity of voices in One Health training, as well as practice. There's the major programs through the One Health workforce with leadership by Afrahun and Siahun that are one example of exactly this. These programs are broadening participation, which is urgently needed in science in general, certainly in STEM, but also in One Health. We especially are seeing how promotion of women and other underrepresented groups in STEM is essential, and we need to ensure that these gains are sustained and supported so that we have equity and participation. I would say that one of my most rewarding experiences as science envoy for the US Department of State was in meeting other women in Asia, Latin America, and Africa, and the Arctic, who are earlier in their career. And through the work that I did with my collaborators at the embassies, we created opportunities that facilitated the networking of women in science, especially early career professionals. And this networking we found was essential for them having a safe space to share the challenges that they still face, to be able to provide support to each other in facing these challenges, and to be able to collectively elevate their own voices in the work that they needed to do. And so, as has been mentioned, we need to ensure that international policy enables and protects this sort of broadening participation in forming a policy. And then I would also add that policy then in turn protects the scientific enterprise worldwide. As we know, as you all know, scientific discovery has ensured societal progress for centuries. But of late, it feels increasingly like we are the bearer of so much bad news. We noted sort of all the things that have come to, in some ways, produce harms to society. You know, pesticides cause decline in bird species, pollution and runoff are causing mass fish kills. Climate change is going to bring about rising sea levels and droughts and floods and fires, as it already is doing. The way we produce food and interact with wildlife bring about emerging infectious diseases. In many ways, these efforts have increased the recognition and the proof of concept for the One Health approach, but we really need to make sure that science can continue to inform and benefit society, and that we actively engage, encourage, and protect this next generation of scientists who are willing to tackle these challenges. We know that we need to expand our workforce. We want to make sure that these new colleagues that are engaging in this workforce feel supported, that they feel that science is going to be a productive future for them. And we need to expand this given future trends. And I think a major challenge to effectively implementing some of these approaches is that the sort of scientific enterprise is not being supported as it once was. And just from my perspective, from the One Health approach, we know that veterinary and environmental science expertise is still lagging in many countries and hasn't really even got off the ground in the way that it needs to. So I just want to end that with this in mind. We need to make sure that we actively collaborate with each other with the understanding that we know that this makes work harder, it takes longer to do the work, but brings about the diversity of the expertise that is absolutely necessary for these greater achievements that we need to accomplish. And specifically, we need to find scientists outside our own disciplines, work with researchers in other countries, and engage our diplomats. This broadens our collective understanding about what is possible, and most importantly, allows us to think more creatively about how we're going to address these global challenges. So I'll end with that and turn it over. Thank you.
Thanks, Christina. Clear voice of someone who's both a researcher or a leader in the field, and is an analyst and a practitioner. And I think we got a lot of messages on realizing that One Health is a great example of where trust, communication, interdisciplinary issues are absolutely at the forefront, as we're realizing domestically on the H5N1 response as well. So thanks, lots packed into your presentation. And last but certainly not least, pleasure to introduce Dr. Rebecca Katz from connected both to Georgetown University Medical School and the School of Foreign Service. She's professor and director of the Center for Global Health Science and Security, which in full disclosure, I'm also an associate of. And Dr. Katz has been teaching about global health and global health security from a number of perspectives for several years, and it's great to hear her perspective today. Rebecca.
Jimmy, thank you so much. I'm going to be really brief with my remarks and really just focus on some of the issues that have already been alluded to, because it's really easy for me to go last and say, yes, I agree with everything else that's already been said. And I'm also quite keen to get to the Q&A. So I am really delighted to be here and talk about one of my favorite subjects, which is how do we train the next generation of health diplomats to meet evolving needs of the field. I also I want to say hello to friends and colleagues from around the world who are on the webinar today. It's really exciting to see the level of interest. And I'd also note, since Victor actually mentioned it in the last panel, he talked about the pandemic fund. And I'm going to call out some of my fellow technical advisory panel members to the pandemic fund are on this call. And I actually would say that the TAP, the technical advisory panel, it's a perfect example of being able to directly apply technical knowledge and scholarship to support decision making and be part of these larger global health decision making efforts. So it's actually a really wonderful example of that. So as Jimmy said, I've had the privilege of living in both the academic and government world for the last few decades. I'm a professor at Georgetown, and I think I'm the only one with a joint appointment in both the medical center and the School of Foreign Service. So there aren't that many of us, and there needs to be more of us. And I also currently act as a very part-time senior advisor to Ambassador Nkegasong. And through these lenses, I've been able to witness kind of firsthand the role of health diplomats and the need for professionals who are able to bring together technical and diplomatic skills to be able to save lives, to enhance foreign policy and national security, try to navigate those stakeholder equities to try to improve population health. And I've been teaching global health diplomacy as a discipline for almost 2 decades as well, including at the School of Foreign Service in Georgetown since 2016. We currently offer a number of courses along a spectrum of learning and at different levels. And Anders spoke about the really exciting training that's happening for kind of early professionals or even mid-career professionals in the field. I like to start a bit younger. So I actually offer an undergraduate course in the Science, Technology, International Affairs program, STIA, at the School of Foreign Service, which gets folks very early on in their training to start to think about health and health diplomacy as a core area of international relations, and for the health-focused undergraduates to start thinking about the policy and the politics and the diplomatic issues as a core area that impacts their work. In addition, I also teach a graduate course through the Security Studies program, which gets a whole bunch of other folks who normally wouldn't touch health. And we offer a summer institute for working professionals, as well as an executive intensive course at our Doha campus, which I am off to teach in a couple weeks. We've also been engaging in scholarship over the course of the last 15 years to try to identify core competencies for those engaged in health diplomacy, trying to create curriculum for foreign service officers, for military personnel, humanitarian organizations, and also thinking about what those gaps are in the training and expertise of public health professionals. And this year, really excited, we launched a new graduate certificate in health diplomacy with the goal to try to prepare students to work in a variety of environments, to try to engage in that multilateral, bilateral, formal and informal efforts to try to advance health and foreign policy. And the certificate is now available to all graduate programs and disciplinary studies in the School of Foreign Service to try to fill those gaps in knowledge and provide the training necessary to operate effectively in the health diplomacy space. And the hope is that after an initial effort to launch the program and make sure we're doing it right, and assess student interest, the ideal is to be able to eventually coordinate with other parts of the institution. And our hope is that eventually this type of training would be open as an add-on to students enrolled in all sorts of different programs across the institution to get at that multidisciplinary aspect. So as such, we really tried to design the certificate in a way to fill the gaps in the curriculum, build on the disciplinary studies of specific programs. And for anybody who's interested, we can share the link to the website. We also happy to talk in detail about the curriculum design and the different types of learnings that we're trying to instill as we build up the workforce. Now, I'd also want to quickly mention, Ambassador Nkegasong mentioned it in his opening remarks, but we have just recently launched the Kolker Fellowship in Global Health Security and Diplomacy, hosted by the Institute for the Study of Diplomacy at Georgetown. So this is my opportunity to embarrass Ambassador Kolker as he's on the webinar, and also to thank him for his service and everything that he's done. And we're really excited to have been able to name the fellowship after him. And so what this is designed to do is to further the academic and professional development of a current State Department employee. And they are able to then spend a year with us at Georgetown through the Institute for Study of Diplomacy and contribute to scholarship, to teaching, ideally to capture knowledge and feed that back in to the training and the case studies and the material we have to then strengthen the diplomatic corps and their areas of expertise in global health diplomacy. So all in all, it's an extraordinarily exciting time. We're excited to be part of what Anders is building and to be able to link with academic institutions from all over the world who are also building out their training in health diplomacy. And again, along a wide spectrum from everything from those 18-year-olds all the way through to the mid-career professionals. And like I said, it's just an exciting time to be doing this, but it also feels a little bit like we're on the edge, right? Where there's tremendous opportunity, there's a lot of interest, and now we have to execute. So now is the challenge. And for those of you and the several hundred of you on this webinar who are in academic institutions, you'll recognize very quickly that executing can sometimes be more complicated than getting something done in government. But there's opportunity, and again, delighted to speak in detail with anybody offline about what the path that we followed at Georgetown. Thanks.
Thanks, Rebecca. And indeed, you embarrassed me in part because I thought that these sorts of fellowships were only named after people who had already died. And it was very reassuring that I didn't have to change my status to have that recognition. And I'm grateful for that. I'm going to ask a follow-up question to each of you. And then we have some very good questions also in the Q&A in the chat. But for yours, there was an earlier question which an anonymous questioner said, how would you convince a university president to make an institutional effort to highlight global health? And I thought you were the right person to ask that question because you and John Monahan and others at Georgetown succeeded in that. Georgetown now has a university-wide program highlighting global health as one of the university-wide goals. What were the steps you took, and how is this working?
Well, I would say it's not the steps necessarily that I took, right? We actually have a couple of other people from the university who are on this call today. And I think what we realized at Georgetown, you might be realizing at some of your other institutions, is that we were really doing global health in a lot of different places within our own institution. And from tremendous interest amongst undergraduates to interest in different graduate programs, some which had like global health in the name, some that didn't, but we're still actually covering a lot of these things. And even as Christine said, there's so many disciplines that are engaged in these spaces that sometimes it's not obvious in the name. But we were fortunate to have leadership at the institution that kind of saw this, and also people like John Monahan and others who were able to kind of guide the president's office. So global health, yes, now is one of the key areas of interest from the university. It doesn't mean it's easy though, right? There's still a lot of different departments and programs and things, and trying to coordinate all of that within academia is not necessarily always an easy path, but still a really exciting opportunity to try to do that.
But you have students from different disciplines who are part of a core each year of kind of internal internships or fellowships for their practicum, right?
Yeah, it's actually really fantastic. The one thing that the institution did early on was commit to something they called the Global Health Institute Fellows. So for a relatively small amount of money, the president's office of the university funds students, whether they are undergraduates or med students or law students, and it's almost like a match. So students, usually 50, 60 students apply every semester to be these fellows, and they get matched with faculty who are interested in working with them, and they are paid for by the president's office. And these fellows have gone on to do really, really exciting work. I will say, actually, we actually have this is the plug time. I had a book come out a couple of months ago, co-written with one of my former fellows from that program. So, they get to do really cool stuff.
Great. Christine, I wanted you to just say a word about the Science Envoy program, because we may have people here who don't realize that the State Department has an opportunity for people to work who are academics or in their current positions to work part-time just for a given period with the State Department. But you also mentioned the Afrahun and Siahun, which are connections with schools of veterinary science and public health in Africa and Southeast Asia. And one of the questions I had, both for those programs and for your own, is where are the jobs? We're training marvelous people to work in One Health, to work in veterinary science, to work in outbreak and health security in the United States. But I don't see institutions like mine, the State Department or the US government, hiring anyone, or certainly not enough people, that as many as we're training. And how do we deal with the fact that these people have expectations, but outside of academia, there may not actually be policy jobs that take advantage of the skills that you're training? I know that's a tough question, and you're in control of the answer, but I'd be interested in your perspective.
Yeah, such a tough question, and a great question. First, maybe I'll start out by answering your mention of the Science Envoy program, which is something that the U.S. Department of State does to basically pull in academic experts in a whole range of fields. And so I was actually one of 7 last year, the only one focused on global health and diplomacy. The others focused on everything from oceans and health, climate and forests, illegal seafood, all sorts of engineering and computer science fields that really could benefit from sustained cooperation across continents and countries. And so I think it is really another example of one of the amazing things that the U.S. Department of State does that I think very few people know about. I certainly didn't know about it until I got an email asking if I would be interested, and I would just emphasize how, from my perspective, how game-changing these programs can be in terms of not just allowing us to help do the work, but then bringing that knowledge back to our careers and our trajectories in academia to, as Rebecca's saying, foster the next generation in this way that really, in many ways opened my eyes in terms of the opportunities. And then to your second point, as where are the opportunities? I think this is always an issue. And I know, are there job opportunities spans many fields, not just ours. I have 2 kids coming, getting through college and looking for where are the opportunities. And I think it's constantly always looking like, you know, that economic picture is always of concern. But I can tell you from certainly from a veterinary perspective, a One Health perspective, and a public health and global health perspective, it is way better than it used to be. I think there were a handful of people working in these fields decades ago. This workforce has massively grown. I think we are anticipating in many ways by developing and expanding the workforce, like you said, through the One Health Workforce Next Gen program and work that USAID has done, as well as lots of other programs around the world, in anticipation of what are effectively global crises that are on deck, that are happening soon. And increasingly, folks that we've worked with have gone on to those positions in ministries, in government, in the nonprofit sector, and not just academia. So in many ways, we're hoping to enable practitioners that certainly could work in practice as well, but increasingly are being able to be supported and engaged in the public health and environmental and animal health ministries wherever they are, to be able to provide that much needed expertise. So it's not as good as it needs to be, as you said, but it's better than it was.
Great. And Anders, several people have asked for the link to your what is it, Politics and Leadership for Health Diplomacy course. So if you could provide that at some point, that would be great. And you had volunteered, I saw in the Q&A, to answer on live several of the questions, or a couple of the questions
I think
over
it
there.
was me clicking a bit too much, so you decide.
No, no, please, why don't you pick one of the questions you volunteered to answer live?
I mean, one question that was coming in the chat right now was about, should we integrate more of health diplomacy and politics also in the undergraduate, in the medical training? And this goes back a little bit to what Rebecca is doing. Well, I'm deeply impressed by what you're doing, and we have a lot to learn from your work. I definitely think we should, and we are doing that in Sweden. Sweden is a small country. We have 6 medical universities. When I started medical school then at the Karolinska in 1982, there were no training in global health, except in one course in Uppsala. How we did it at that time was to come together the students to push. The president of the Karolinska absolutely didn't want this, but that was students' pressure at that time. And today, we are integrated in the basic medical training. I've been teaching today, this morning, in the new master program. So we have a module in the master program. So you can have it both. I mean, as you're doing, Rebecca, already, I think part of integrating it in the undergraduate programs, in the master program, and then we're doing this other specific programs, which is more of an executive program. But what I think where we need to spend some more time, and again, the collaboration we have established is also to spend some more time in terms of what are we teaching? Because quite a few people that are teaching global health diplomacy or speaking about global health diplomacy, they are speaking about global health.
Good point. I think, yeah, Andres Diaz's question specifically was, medical school is very demanding and quite rigorous and following a precise pattern. How did you weave in the policy skills? How would you do that for medical students? And then Roberta Andrade talks about having a 2-week practicum. Is this something that you included in your program, or do you think is practical?
I mean, what we do again in Sweden, I mean, we are integrated into the basic training, but also there are executive courses that you can choose. And they are very popular among students, including also going to Uganda or to India, etc. What we try to include in those programs today, because they used to be classical global health programs, teaching about maternal and child health, etc., is also to integrate more of a political sort of dimension. Basically speaking about not just what to do, but what made it possible. How did it happen? What I was using as an example today when I was teaching was, how did we move from the MDG to the SDG? What was the political process behind that? Who did it? Why did we do it? How was it possible? Because then they had started the program learning about basically global health challenges, SDGs, etc., Agenda 2030. But what I spoke about was, what was the political dynamic behind that? Why did we move from that to that? And I think that could be, I think, of great interest. You can take tobacco legislation. I mean, how is it happening?
Well, the other question I got from the Q&A that I wanted you to address is possibly relevant to exactly that. Patrick Dacom earlier in the other panel said, how do you build sustainable systems that withstand changing political leadership? How do you build sustainable health systems and global health engagement that can endure during times of changing political leadership? A question many people in the United States are asking themselves.
It's a huge question far beyond what we're speaking about now. I mean, if I should give a very simple answer, is to make sure that you have true democracy. That you have true democracy with good governance and transparency. I mean, that's the most important.
But are there multilateral commitments, for instance, that can help keep us on track? There'd be a political bindingness to those commitments.
No, I mean, in some way, all what we have at the international level are political commitments. They are not legally binding. I mean, the only thing that we have which is legally binding, Alex knows this very well, is the international health regulations and the ones that have signed off to the Tobacco Convention. That's it. But of course, I mean, the Universal Health Coverage UHC declaration in 2019 in the UN, where we had, I don't know how many heads of states, and we had ministers from all countries signing off to say, we are going now to commit to work towards UHC. And in some way, UHC will also require robust and resilient health systems.
Very good. Question. There was one question for any of you about in the Q&A about equity. How do we build equity into our systems? I know we had in the previous panel about NIH funding, which goes predominantly to US institutions, where we also heard that institutions in low and middle income countries now are very robust and have their own research agendas. But even then, we're talking about grants that go essentially to elite educated people and may not reflect the variety of health needs of their populations. Do any of you have thoughts about how we as academics or policymakers build in the consciousness that we may not be reaching the most vulnerable or the most important audiences?
So Jimmy, can I buy a little bit of time on that for everybody? And actually just, I had one other quick point I wanted to make in addition to what Andrew was saying about how we train and specifically thinking about like how we would, if you wanted to train medical students, right? And I just wanted to quick note that I think that we're using words that could be interpreted a lot of different ways. And, you know, if we want to train medical students to, you know, just understand the context within which they're operating and, you know, to be able to kind of know what, to Andrew's point, know what the SDGs are, or know some of the political context, or understand how, if they are engaging with partners around the world, where the informal diplomacy aspects of that might look, you can do that in 2 weeks. If you want medical students to be able to walk away with the ability to do what you and what Anders have done and sit in the World Health Assembly and negotiate text and be, that's possible as well, but that's a different type of training. And if anybody on this call has friends in philanthropy who want to, you know, donate the tuition to be able to have those students in school for another year, we can do that, and we can do that training, and we can set them up to be able to be better positioned to be able to jump into those positions later on. But that's not a 2-week thing. So yeah, so that's not addressing the question of equity. And now Christine can take the hard question. How's that?
Thanks, Rebecca. Please, I'll jump in. It's such a good question. I think as researchers, we are fundamentally tailoring our ideas and our work to what the funding entity wants. And so that is a huge carrot, right? And I think that if the needs are well outlined in a request for proposals, I think that's what the researchers will endeavor to do. And I just want to share one example. I'm part of the NIH and NIAID Centers for Research in Emerging Infectious Disease. And in addition to all the work that we heard about with Fogarty, these research centers have the sort of mandate to collaborate in an equitable manner with other colleagues in other countries where, we all experience emerging infectious disease outbreaks. And work together globally. And there's also funding mechanisms where specifically the PI is designed and meant to be a colleague from a lower and middle income country that has not had that opportunity before. So you can create the opportunity that way, and then you can also mandate within the funding mechanisms that they collaborate with communities at risk, that they consider who is most vulnerable for whatever the topic or field is, and that is what is tackled as part of the research. So just one example.
Can I add something on that, Jimmy? Because when you speak about equity, and then sort of natural answer is that we get data to show the differences, the gaps. The reality is that closing the gap is a political decision. So, I mean, what we can do, what academic institutions can do, I think, again, I'm coming back to the political science and the policy analysis or political analysis, to equip people also with the knowledge. How do you do that political analysis? Understanding where is power? Who is for, who's against? Why are we moving towards closing the gaps or not closing the gaps? Those are purely political decisions. But there is a way, if you spend a bit of time and do some training, to be able to learn to read the landscape in a more effective way. And then you might be more successful, because only coming with the data to say, here we have a big issue, I don't think that's enough. I think we need to be smarter than that.
No, I'll just reinforce that from my experience, that there's so many times that I dealt with health professionals and scientists say, well, we know what to do. We're just lacking the political will to do it, as though political will was a light switch that you could turn on and off. And the question is, how do we use the data and evidence that we have to incorporate it into persuasive arguments, to get it onto the agenda of policymakers, to make them own the argument, and to recognize that they and their own agendas would be better off if they took the measures that we're advocating for. And that's not easy. It takes time, but it also takes some thought about trust, about communication, about, as Alex Phelan talked in the earlier conversation, about getting a champion within the system to be the advocate for the programs that we're talking about.
But I think we also need to join hands and ask for help from the political scientists. There is a science of politics as well. There's not just a science of medicine.
Yeah. I would.
And Christine, you're working on science. I mean, there is much more advanced science diplomacy and understanding in using this than what we have in the global health community today.
Yeah, I would be, and I'm not the first to say this, others have said it far more eloquently, but I would be the first to admit that as scientists, we have no idea really how to influence policy or how to get the work done that you're talking about. We absolutely cannot do it ourselves.
So I don't know if Anders is thinking of the climate realm, but they certainly have had to go a long way to try to influence policy and to get governments to take decisions that are hard, and where there are a huge number of stakeholders with huge economic interests and traditions of doing things a certain way that have had to be changed or at least challenged. And so I think Anders is right that there are people who have been through this, some successfully, some less. Is that, Anders, was that what you had in mind?
No, absolutely. I think we can learn from history. I'm writing a chapter in a book now about what we can learn from what we call defining moments in global health history, on especially this, how did it happen? So we've been interviewing Peter Piot with Michel Kashachkin, Asi from Senegal, etc., etc. We've been interviewing now 10 people to try to see why was it possible? What happened? The leadership, the establishment of some sort of informal structure that helped move towards the formal decision, the pressure or the help from civil society organizations, of course, then having the data and the science, of course, that was critical, especially when we spoke to people who were involved at the early days of the HIV/AIDS outbreak. That was important, but that was not enough. Then the question is, and that is for research right now, why have we not been more successful now after COVID-19? That's, I think, is a big, big issue. I mean,
No,
the world was paralyzed,
excellent point.
still the world is still not doing anything. Why?
Right. COVID clearly put health on everyone's agenda, but we've kind of again lost the thread. If
Yep.
we're advocating for books, I'll just be a little self-serving, and I wrote a chapter called Health and Science Diplomacy, and this book has many chapters about it called Diplomatic Tradecraft, which is designed as an academic textbook for people who may be teaching about diplomacy, but there's a chapter on health and science in that. Great. I guess we have just a couple more minutes, and the one question that I thought was great from Catherine Stollards, that how does government engage in the global health academic spaces? They're both, we're asking for this to happen. We want greater engagement, but are there, I don't know if this was the purpose of the question, but are there dangers in that? Do you want in some ways for government to keep out of your academic spaces? Christine, Rebecca?
I could just say I want government to tell us what the questions they have are, and that to me is some of the most important requests that I get, that I will tailor my research to accomplish, to be able to serve in that way.
Okay, great answer. Rebecca?
I mean, I do the same thing. I think not everybody wants to do the research. Not everybody wants to answer the questions that the policymakers are posing. And in fact, it's actually not often aligned with the funders. And you pointed out before, we're often beholden to the funders. Yeah. And so it gets a little complicated, but I think there is a really very rewarding path where if you are designing research and you are designing scholarship based off of what you know are the questions that are going to help influence decision making. And I'm going to go back to Victor's language from the first session. It's evidence informed, it's not evidence based decision, right? Because you have to understand all the other factors that are going into a decision. But I think that can be a really, really wonderful way to engage scholars and engage academia and bridge those ties, whatever. Yeah.
We have some wonderful comments in the chat, but it is time for each of you to have 1 minute just to give a last thought. Rebecca, you're on my screen. Can I start with you? Any last thoughts? This amazing audience that stayed with us for 3 hours, 2.5 now hours, and CUGH is going to have plenty to follow up on in their open sessions and their conference. But what message, how can the State Department, you know the State Department well, and you know the academic world well, what can we do as a State Department to take advantage of the wisdom that we have, and what can academia do to take advantage of the needs of policymakers?
Yeah, I've got nothing that can be summarized in a soundbite except to say that I mean, this event, this conversation that people have been having for the last few hours, I think is incredibly rewarding. It's a great step in a positive direction, and you know, from the fellowship opportunities to the training opportunities to even just having these conversations to the conferences where we're starting to see more academics and scholarship presented right next to the decision makers, and being able to have those direct connections and build these communities, I think it's where the future is, and I think it's what makes the academic work relevant, and it makes the government work you know, in line with the latest scholarship. So I'm just here for it.
Terrific. Christine.
Thank you. I think, as was pointed out, one thing I would love to emphasize is that when any one of us are tackling any problem, that we make sure all the relevant disciplines are engaged. I think that was emphasized a lot, and something I would love to reiterate. As Ambassador Coker said, I think we need to track the trends in our workforce, make sure that we understand the challenges in terms of access, but continued support, whether that's through research or engagement with diplomacy, but and ultimately in employment, to make sure that we are always tailoring our work towards that. And I just want to also echo that it's been so exciting to see all the participants on the call. You all are essential to making this world safer, better. I encourage you to find someone new to work with at every opportunity that you possibly can and make lasting connections with each other, because that is definitely going to make us all much brighter and more hopeful. Thank you.
Well, thank you, and your contributions have made me brighter and more hopeful. Anders, Dr. Nordstrom, last
Thank
word
you.
before
Thank
we
you,
turn it
Jimmy.
back to our leaders.
Yeah, no, thank you very much, Jimmy. The first thing, as I said, we are at the very beginning of creating a network of institutions that are specifically interested in building capacity in health diplomacy. 31 institutions right now, 9 programs or institutions that have programs up and running. We are not ready yet. We are on our way to create a web page where people will be able to navigate and see which programs are available, but it will come. It will take a bit of time, but we are at the beginning of that, and there is enormous interest for it. Second, research. I'm coming back to sort of the interface here, public health and political science, more resources for that. And not just trying to influence diplomats to learn health. It's about also the health people that needs to learn diplomacy and political science. And my last sort of message or advice is that if you're not a politician, many of you have, at least here on the panel, have been working in political environment. I've never been a politician, always been a technical person, but speak to the politicians. Ask them about what is your reality? What is your rationale? How are you thinking? What makes you take those decisions? Talk to them. Because there is a logic to politics as well, even if you don't believe it.
Fantastic. Now, the very last question in the Q&A is whether London School of Hygiene and Tropical Medicine are part of your are involved in their part of your network, I know. So that was an easy one to reply to. And I think they're going to be part of CUGH's.
No, and that's
Peter Piot was part of your program, wasn't he?
Yeah. No, they are.
Okay, great.
The one in the UK is in Oxford.
Very good. Keith Martin, John and Kengasong, can you, I don't envy the challenge of wrapping this up. There was so much that went on, but let me turn the floor over to you again. And thanks so much again for Keith, for CUGH organizing this and being the platform on which we could have this discussion.
Well, Jimmy, really enormous thanks to you. Wonderfully bringing in your many years of expertise and integrating that into the.
So let me just say, Jimmy, that that someone should bring me my video on. I mean, it's impossible for me to come on.
Dr. Kinson, did you want to go first and I can go second, or would you like?
No, you go ahead. I just wanted to raise an alarm bell that they bring my video on, but I'm back. I'm good.
Fantastic. Well, I think Dr. Nkengasong and I were just going to close, and Dr. Nkengasong will go after, have the final word, of course. I think Ambassador Coker, bringing your so many years of expertise, and with the wonderful panel, really much thanks to Rebecca, Christine, and Anders. And as somebody who spent 18 years as a politician, as a policymaker in Canada, as a member of Parliament, you interrogated and shone a bright light on the practical realities. And I can just say that one of my frustrations as an MP was really the amazing scientists that would come into my office with large tomes, amazing reports, practical solutions that are not going to be read by the minister and that's tragically would not be used. So in the session that you held and what we've heard in our panel, the first, a couple of sort of big points. One, knowledge is not enough. It is not enough. Second, decisions are local. Decisions are made by and for, rightfully so, by the countries themselves and going right down to the communities, as Christine had mentioned. Also, Christine mentioned the point, what does academia need to know? The big question. And Rebecca really challenged, in a way, funders, that funders, you need to be able to incentivize the practical solutions that have been proffered here in the 2 panels that we held. We need you to incentivize these actions. These actions will help you to achieve the impacts that you want to have so that you have long-standing impactful work to address the big challenges before us. And one of the big things that we hope that can come out of this is that how do we get this information to academia around the world? A site that the State Department could have to have virtual real-time knowledge about who are the right people to speak to, as Andrews mentioned. Who are the power brokers? What do they want? Their information is on one side of the equation, and the rest of us are on the other. There has to be some practical way to do that, and nobody has a better sort of insight into that than the incredible diplomats that work around the world in embassies. They know who to speak to. They've built those relationships up of trust, and that can be the interlocutor to be able to connect needs with capacity. So I'll just close again by saying that I hope that that those of you who can will come to our virtual week at the end of this month, September 30th to October 3rd. You're all welcome. It's free for everybody. And also to our conference in Atlanta. And you can find all that information at cugh.org. And I'd like to thank the team at the State Department, Teresa and Samuel, Sarah McGee in our office in Washington. And finally, Dr. Nkengasong, thank you for including us. Thank you for engaging with CUGH. From all of us at CUGH, we look forward to working with you and your team at the Bureau to be able to achieve the common issues, the challenges, and the common mission that we have to have a safer, healthier future and for all. Thanks so much. Back to you, Dr. Nkengasong.
Thank you, Keith. And without the partnership and collaboration with you and your network, CUGH, it would be impossible to have this successful panel. I think at some point, after about 2 hours, I look at the number of participants. There were still over 304 participants on Discord. That's a large number of people, and it shows the interest and value of this platform. We are a new bureau. We just, as I indicated earlier, celebrated a 1-year anniversary in August. But it really shows, I would not try to reflect on the academia part of this, but you already have lined that up. But let me rather reflect on global health and diplomacy. I think it's suffice to say that when diplomacy works, global health wins. I mean, period. I think we know that Anders asked a very fundamental question, and he said, why were we very successful with HIV, but not successful with COVID? I think part of the answer is diplomacy. I mean, diplomacy worked in the early, it worked in a miraculous way in the year 2000. In the year 2000, we all know for the first time, the UN Security Council issued a resolution 1308, which essentially that was July 17, and where the United States tabled that resolution and it was endorsed. And I recall that at that time, the ambassador to UN, Richard Holbrooke, thanked the Security Council and in quote said it was unprecedented resolution on the health matter for the first time in the history of the Security Council. That was remarkable. I think that is, and we know the impact of how that resolution stimulated the response to HIV/AIDS and steered it in a whole different direction. Then, because of diplomacy, again in June of 2001, the UN General Assembly had held a special session on HIV/AIDS, which was hailed as a watershed moment at the UN. And all of those events in the early 2000s led to the creation of Global Fund, and I would actually say also directly or indirectly stimulated the discussion that led to the establishment of PEPFAR, which had both initiatives have saved more than 50 million lives. That is, if you combine the 3 diseases that the Global Fund is focused on: HIV, TB, malaria, and PEPFAR. So again, it always speaks to the power of when diplomacy wins. When diplomacy is successful, global health wins, and global health security, of course, wins if global health wins and good public health practice work. And none of that would have been successful without the very strong leadership role that academia played. And you know that, as I said in my opening remarks, that it is only because of the very strong university engagement that PEPFAR was able to take off, right? When we started up with messaging with 3 goals, we wanted to put 2 million people on treatment, 7 million new infections prevented, and care for 10 million people. Only academia in the US stepped in to help achieve that goal. I think, again, that is why the State Department is really looking forward to a strong partnership with the universities, academia, to really scale up the concept of global health diplomacy, scale up the concept, the partnership that universities and academia play, not just in the US, but abroad. I'm really looking forward to strengthening the partnership with Andes and others that we already have discussed in this forum. So thank you very much. I'd like to end by acknowledging the hard work of the staff within GHSD that have really worked over the last couple of months. Jimmy, thank you for your leadership, and the entire team for bringing this forum together. And let's make it happen. I think we are committing ourselves that as a bureau, we will continue to use this platform and strengthen it as much as possible and make it innovative. But we are counting on your partnership as you've done today. Thank you.
Thank you, everybody, for joining, and thank you, Dr. Nkangasong. And this session, the symposium, is recorded, and it'll be sent out to all of the participants. So have a wonderful day, everybody, and thank you again to everybody who stayed on to join us. Keep well. Thank you.